Yes, ma'am, we are live now.
Yeah, good evening. Welcome all of you to this Caesarean section workshop. The workshop is being conducted under the aegis of societies of Behrampur, Burla, Raurkela, Sitamarhi, and Muzaffarpur. So let us begin the webinar with the auspicious lighting of the lamp and prayer song. Thank you. Thank you. Yes, we are blessed to have our chief guest, Dr. S.N. Tripathi ma'am, and our special guest, Dr. Angila Sinha ma'am, who's a great source of inspiration. And we are truly blessed to have them over here. And very soon, I think Dr. Madam Bharti Mishra will be joining us very soon as guest of honor. I invite Dr. Sadhna Gupta ma'am to please welcome our chief guest, special guest, and guest of honor. As we all know, Madam is the most able and a great academician and a very, very hardworking person. And she's also a presidential candidate for Foxy for the election year 2023. We welcome all of you. Madam, over to you.
Thank you, Ritu. And it is once again a great pleasure to be with Odisha and the Bihar Society. And सबसे पहले जय जगन्नाथ
नमस्ते
जय जगन्नाथ जी के आशीर्वाद हमेशा हमारे साथ रहे और हम सब इसके लायक बने कि उनका आशीर्वाद के काबिल रहें और इसके साथ ही जस्ट आई अ बिग थैंक टू सोसाइटी ऑफ बहरामपुर बुर्ला राउरकेला सीतामढ़ी एंड मुजफ्फरपुर Dr. Sangmitra Mahapatra, Dr. Indra Palu from Behrampur, Dr. Ojaswini, Dr. Leena from Burla, Dr. Dilip Sahu and Dr. Lopa Mudra from Raurkela, Dr. Anju Singh and Dr. Lata Gupta from Sitamarhi, and Dr. Neelam Sinha and Dr. Sadhna Sinha from Muzaffarpur Society. Because only with your effort and the coordination, we are today here. A little word about this CE Classic for Clinician series. Why this word? It is because in the today's world, when we are having always a very rapidly advancing information, sometimes inconsistent, sometimes conflicting, we need to have that a very, very strong basic foundation for the teaching what our teachers like Dr. Ragila Sinha, Dr. Tripathi Madam, Dr. Gangadhar Sahu, Dr. Bharti Mishra, they have set that stage that our foundation for the basic knowledge is very, very strong and which is always been modified and adapted as per our ongoing research, ongoing our experience and the expertise. So it is it is an ongoing series, around 1.5 years, and we have covered many subjects, and today we are taking cesarean section operation, which brings a lot of bouquets as well as bricks to our fraternity. We are always in the searchlight by the people, media, what we are doing, why we are doing, and sometimes it is so difficult that how we readapt to the people's expectation, new technology and incidents at the base of cesarean section. So we are looking ahead to a wonderful session, and it is a great honor to have our mentors of mentors with us today, Professor S.N. Tripathi and Dr. Ragila Sinha and Dr. Bharti Mishra, to grace this occasion with their blessing. Dr. S.N. Tripathi has been my mentor and many, like mentor of many people across the generation. And her blessings and guidance is a real source of inspiration for us. She has been professor and head of the Department of OB/GYN, SCB Medical College, Cuttack, an erudite scholar, superb teacher, skillful orator, author of many books and literary field. I have really gone through about her wonderful article about the Lord Jagannath, and it is a real pleasure to read to her writing in English translation. It must be very, very enjoyable in Korea in her own like basic writing language. A well-known figure in India, and her work for the tuberculosis has been a remarkable work which has been recognized at many, many national and international forums. She has been the patron of ISOPARM, and actually the Gorakhpur chapter of ISOPARM is only the blessing and the order of Dr. Tripathi Madam. She has been President Association of OB-GYN Society of Odisha in 2000-2001 and President ISOPARM from 2010 to 2011. So, Madam, we are really honored to have you, and we wish to have your words for the pulse of wisdom.
Thank you, Sadhana. And you are very dear to me, you know. And our special guest today is Madam Sinha, Rangila Sinha. So many days afterwards, I'm seeing her. Bharati has not joined, and she will join. I think she will definitely join. The conveners, my dear Mosami and Ritu, all the Foxians of Odisha, those who have joined, and Sitamari and Muzaffarpur, very good evening to all of you. I am grateful to the organizers for inviting me to this August gathering and for a subject which is now a burning subject, so to say. CS, though a common topic, all of us do it daily for some indication or other, but is also a very sensitive topic due to the changing scenario of our lifestyle, our scientific achievements to have a pregnancy where few decades ago we were not thinking of. When we were students, the indications were very few, and the rate was about 10 to 15%. Now the rate has gone up to 45 to 55%. That is really a great issue. So many issues are there with this, why it is rising. People are demanding that they should be done elective Caesarean sections on demand. Then assisted reproduction has come, a pregnancy with assisted reproduction. We don't want to take any risk, so do a Caesarean section. And our pregnant population now, primary gravidas, are elderly. They are career-oriented. They are becoming pregnant in a late age, and late age diseases are there, like diabetes, hypertension, and many more diseases. So we do go for a Caesarean section. So Caesarean section rate is definitely rising. Along with the increase in ages, there we have to do Caesarean section. You will all agree with me that maternal mortality is definitely higher than normal delivery in Caesarean section. That all of us will agree with me. And what else has increased with that? The morbidity rate has increased so much that we cannot just imagine it. Why it is increasing and what are the new ones? For some years, we have already not had a rupture uterus case. But now, because of Caesarean section, we are seeing rupture uterus cases. Scar ectopic, have you ever heard it? Now we are having scar ectopics. And the PPH rate, which was very less, now has increased to a great extent because of placenta accreta, increta, and percreta. So now the time has come that we all should combine together how to reduce this Caesarean section rates. And this is a very good topic Sadhana and his team have chosen, and we all will agree that this workshop will definitely find out a way that how we'll reduce the Caesarean section rate, and along with it will reduce the morbidity and mortality due to cesarean sections. And I don't want to take more time. And I wish the workshop a great success. And my blessings to all of you. Pranam to Madam Sinha. Jai Jagannath.
Thank you very much. Thank you very much.
Thank you, madam, for your real words of wisdom. All the things we are having the upcoming modern challenges you have actually covered in a very, very short span, and that sets the stage for today's all discussion. Thank you very much, madam. And it is a great pleasure to have Dr. Rangila Sinha among us, who has been the teacher of teachers, a source of inspiration. And not only she is a teacher, actually her lifestyle and her book, which I have received in person when I was there at Muzaffarpur at her own home, it is so much inspiring that how she could go through all the difficulties in life, all orthodox, all gender discrimination, and it really, her life is a living example for all of us that we should always be very, very courageous, going forward and positive. And at this moment of time, Madam is devoting so much of work to the people's health, taking OPD, teaching everybody, taking so much of interest in the society. So it is such a great blessing that we have seniors like Madam Dr. Rangila Sinha, who has been the head of the department at the Muzaffarpur, and a very, very good hospital, and I'm blessed by two lovely daughters who are as energetic and as good obstetrician and gynecologist. So Madam, thank you very much for being with us, and we look forward for your pulse of wisdom for the today's program.
Thank you very much. I'm very happy. I'm really happy. I was not knowing about this webinar, but I always like. Can you hear me? Am I audible?
Yes, yes, ma'am.
Yes, ma'am.
I like webinar very much because it gives me so much opportunity to see people. See, Dr. Tiwari. So I'm forgetting your name. You are Tiwari. Isn't Tripathi? Yes. Isn't Tripathi is very close, was very close to me. Sometimes I used to go in your place. You have come so many times in Muzaffarpur, and we were in group with Dr. C.S. Dan. You remember everything. And so, and now even if I want to remember the old names, it is always in my mind, but I can't remember due to age problem. So I want to see people in webinar. The moment Dr. Sadhana Gupta told me, I was getting down from car, and then she told that you have to appear. I accepted that I will see so many people I have not seen. She told from Odisha, and your name, then I was very happy that at least I will see Tripathi before I leave this world. And I'm very happy to see all of you. I always like this webinar because it gives me lots of comforts for attending people and seeing and discussing with you, getting new ideas. I can't read so much now because of eye problem, because of ear problem. I try to hear with YouTube, but still I want to keep myself up to date. And I have seen Dr. Sadhana Gupta. I always remember Dr. Sadhana Gupta as a simple girl doing something, very busy in discussing something with some senior. And it was so simple that hardly people will see that she is doing so much. But I have seen from very early of her career in Foxy that how devoted she was in whatever post she was in that time. She was fully justifying her work. And I have got the moment I heard that she is one of the candidates for president, I think that she actually deserves and she should be there. God knows, I bless Dr. Sadhana. And this subject, cesarean section, I think that there might be so many reasons for increasing rate of cesarean section, but one reason is that people have started doing practice. A single obstetrician doing practice, doing obstetrics. It is not possible. It is not possible for a single obstetrician to do justice with pregnant women. So far, her obstetric duration, how can you manage gynec, infertility, and in this maternity case, it demands different patients have their own problem. You have to watch for longer time, and it is not humanly possible for obstetrician doing single obstetrician running maternity. One point I think it is of consideration, but people, they don't want to practice in joint. In joint, they don't want to practice there, and so many in Muzaffarpur, in all cities, they have started their own nursing home. They very good students, they are not opting to go in medical college. I'm not happy to see this trend, because good people should go in medical college, then only these good doctors will come out of this medical college. Everybody is interested in their own practice. Single obstetrician doing their practice, doing obstetrics. The number of cesarean sections will increase. So with this word, I bless all of you. And Dr. Sadhana, I see you that you are fully justified in your career. Thank you very much.
Thank you, madam, for your loving words, invaluable, precious wishes, and observing me, because it is so great to know that the so strong and wise people were observing you right from the very beginning. And
Yes.
that means a lot to us. And I seek everybody's, Madam Tripathi, Dr. Gangadhar Sahu, Madam's blessings, that I fulfill like all my responsibility, and I do my work very, very well. And we will like to work together with everyone. So this is the way ahead. Thank you very much, Madam. And rightly you said, and what we say, Madam Tripathi and Dr. Rangila Sinha, they are so aware of the today's challenges, and they are presenting solutions to us. And it is to us that we carry their vision. They are so aware that how it is difficult to have a single-handed practice, how this thing IVF and the ART issues, and it is coming with the rising cesarean section. So thank you very much. We recognize presence of Dr. Gangadhar Sahu among us. मेरा प्रणाम डॉक्टर गंगाधर साहू एंड डॉक्टर भारती मिश्रा, क्योंकि कई लोगों ने, many people have joined through the Dr. Bharti Mishra, are you there? Dr. Bharti Mishra. So Ritu, we can go ahead with the scientific session, and we will, whenever Madam joins, we will invite her for her address.
Yes, ma'am, definitely. Thank you very much for bestowing your blessings to us, our seniors and our source of inspiration. We are truly blessed to have Dr. S.N. Tripathi ma'am and Dr. Rangila Sinha ma'am. With your blessings, we start with our scientific session, and that is let us begin with the first scientific session. It contains two topics. Topic 1 is indication of cesarean section, a special reference to Robson's criteria, and speaker will be Dr. Sandhya Panigrahi. And topic 2 will be CS audit need of the hour. The speaker is Dr. Indira Palo. And to grace the occasion, our chairpersons are Dr. Dilip Kumar Sarangi sir. He is President ISOPA Burla Sambhalpur chapter, and he is a renowned obstetrician and gynecologist. We welcome you, sir. Then Dr. Stuti Khare ma'am. She is senior consultant IGH Rourkela, and she is currently senior consultant at Jayaprakash Hospital Rourkela, and she has special interest in IVF. We welcome you, ma'am. And our third chairperson is Dr. Sudha Jha. She is a senior gynecologist at Sadar Hospital, Sitamarhi, and she is a scientific secretary, Foxy, Sitamarhi, and has attended many conferences as faculty, chairpersons, etc. We welcome you, ma'am. And now I would request Dr. Dilip Kumar Sarangi sir to please introduce our first speaker, Dr. Sandhya Rani Panigrahi. Over to you, sir.
Just before that, Dr. Sandhya, are you there? Dr. Sandhya?
Yes, madam.
Yes,
Yes, madam.
because
She's there, yeah.
yes, thank you. Yes.
Thank you. Audible, I am? Hello?
Yes, sir.
Yes, sir.
Okay, delighted to
हमको
be
ज्वाइन
in the
करना पड़
company
गया अचानक से
delighted to be in a company of such a learned gathering today. Thank you very much for inviting me for this webinar. Now, can I have the CV, please? Sandhya madam.
Yes, sir.
Hello.
Yes, sir. It just flashed over there. Yes.
Okay.
A CV is flashed.
Okay. Yes. Sandhya ma'am is
Yes, sir. Good evening, everybody.
is live member of Box, live member of IMA Barampur, live member of IMA MS, secretary FCGB Odisha, secretary IMA MS. Long list is there. I'll not take much time. He is a very renowned gynecologist of Odisha. May I invite ma'am for the subject? Sandhya ma'am.
चम्मच लाओ चम्मच ये बंद कर
Sir, I have to share my screen.
Have you made Madam Sandhya co-host? Allow her to share the
Madam,
screen.
good evening, everyone. My slide is visible, madam.
No, not
no.
now. Sahiti, help Dr. Sandhya to share the screen. You, Dr.
Ma'am, I
Sandhya,
have made you co-host, ma'am. You can share the screen, ma'am. Share
Dr.
the
Sandhya,
slides.
yes. You click on the slide share and open your presentation.
Madam, it is not working, I think.
Make her co-host.
Yes, ma'am. I have already made you co-host, ma'am, and you need to click on share screen option, ma'am.
First you share screen and then you click on the presentation.
Madam, is it visible now?
No.
No, ma'am.
You have put on the share screen, Dr.
Yeah.
Sandhya.
Yeah, madam, I am sharing it.
You have to just share. Click on the share screen.
Share screen, I share, madam. I click on that one.
Yeah.
And then click on the presentation also. Click on the presentation.
Ritu ma'am, if you have the presentation, you can share.
Yes, sir. Sahiti, please help her out. Sahiti, are you there?
Yes, ma'am.
Please help, madam.
Ma'am, have you joined from laptop or mobile, ma'am?
Dr. Sandhya, have you joined from laptop or mobile?
Sandhya, ma'am.
By the time, I think, Dr. Indra Palu, you can check your slide share because the topics are interrelated. By the time madam's problem is solved. Dr. Indra Palu.
Yes,
Hello,
Palu
madam.
ma'am.
Am I audible?
Yes,
ma'am. You are audible, ma'am.
Please,
I
Dr.
have
Indra.
already sent my topic to Sahiti Priya. Let her share this.
Sahiti, आपके पास Dr. Sandhya, आप you can send your presentation to Sahiti as well.
To whom, madam?
Sahiti.
Sahiti, आप chat, you write down the mail like on chat box.
हाँ साहिति वो डॉक्टर इंदिरा पालो का मेल आया होगा वो आप उनका प्रेजेंटेशन शुरू करवा दीजिए
Dr. Sandhya, you have joined from mobile or laptop?
Mobile, madam. To mobile.
Then you join,
Mobile.
if there is a presentation, you join from the laptop actually. From mobile, it is difficult. Otherwise you send the presentation to Sahiti. Dr. Indra,
Okay,
you
madam.
Ma'am, we can have Dr. Indira Palo's presentation
Indira Palo,
now,
yes.
yes.
and
Dr.
Indira
Indra,
is
please.
followed by Dr. Sandhya.
Yeah. Please flash her CV. Dr. Indira Palo, ma'am. Yeah.
Sahiti
Indira
madam,
ma'am, I have
can you
not
please share
received the
the screen?
slides, ma'am. Can you please resend it, ma'am?
Sahiti, please put her CV on the screen.
Yeah, sure.
Dr. Indira Palu, yeah. Yes.
Yeah.
I would request Dr. Stuti Khare ma'am to please introduce Dr. Indira Palu. I think Dr. Stuti is not there. Sir, please, Dr. Dilip Pura Sarangi, sir. Please
Okay.
introduce, sir. Please introduce
Yes, sir.
Dr. Indira Palu.
Dr. Palo is Associate Professor, MKCG Medical College, Barampur, Secretary, Barampur OG Society, Life Member, Foxy, IMA, ISAR, SFL, secured first position in first MBBS, and lot of medals are there, published many papers, and our interest is in high-risk pregnancy, ultrasound, and laparoscopy. Let me welcome Dr. Palo to share her slide on the subject.
Dr.
Sahiti,
Indira
you
Palu,
stop
please.
slide.
Yeah.
Please share your screen.
Very good afternoon to all of you. Sadhana madam, namaskar. I my namaskar to all my seniors. Am I audible?
Yes,
Yes,
very
yes,
much.
you are audible,
Okay.
very much.
I request Sahiti madam to share my slides. Sahiti madam, please
Very
share
sorry,
my
ma'am. I have not received the slides, ma'am.
Yes, not.
So,
You can share from your laptop as well.
Actually, to avoid some confusion, I have asked, I have already sent my slide to this madam. Sahiti madam, will you share or I'll try?
She says that she has not received your presentation actually. Something is gone. You can send to me that Sahiti Priya Sheel Healthcare, the mail is there. This is something IT. Can I will start my topic?
Yes, madam, you can start with your topic.
So I think I am going straight away.
Yes, ma'am.
No introduction because the people have joined and they want to listen.
Yeah.
Na?
Yes, please.
So, with my regards to, it is just in a matter of thing. My slides are visible. My slides are visible.
Yes, ma'am.
Yes, ma'am. Yes, yes. Yes, your slides
So,
are visible. ma'am.
First of all,
Make
I
it first.
request Dr. Indra and Indra Palu and Dr. Sandhya that you please send the presentation to Sahiti so that we can have the next slides just after my talk. And my regards to my chairpersons and the session of both chairperson of both session. So Dr. Dilip Sarangi, who was with us yesterday, Dr. Sunil, Dr. Sudha, and Ojaswini, dear friend, Dr. Anju, and Dr. Neelam Sinha. So I'm just taking a little that priority in that interest of time. And I will be dealing what Madam Tripathi have said that we are having now scar rupture and what is we are having a backlash of the placenta accreta spectrum and the scar complication because of high rise of cesarean section. So I will actually merge the two things that what is isthmocele, what is the scar defect and how it lead to scar placenta accreta spectrum, and the most important thing, how we should standardize the cesarean section technique so that we can prevent the scar defect. So it is all about me, and I seek blessings of Lord Jagannath, all mentors, seniors, teachers, and the young colleagues for my upcoming Foxy presidential candidate. And these are the beautiful memories with Madam Sita, Dr. Gangadhar Sahu, Madam Tripathi, and the Puri at the Lord Jagannath Award and Dr. Bharti Mishra. So I owe a big gratitude for staying together in my long journey, 30 years dedicated journey in Foxy. And I look forward that we work together for women health in our country, across the regions, across the socio-economic class and the cultural issues, what we have, our women, gender discrimination, and all the regional disparity between the maternal and health statistics between the different states, and we have to work together. So I bring greetings from land of Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. And why the cesarean section is the topic today, because it is a different surgery, always involving two lives. It is not for the some disease, it is for the physiological function. साहित्य एक किसी मोबाइल से ना कुछ डिस्टरबेंस हो रहा है, देयर इज सम लाइक नॉइज, अगर आप उसको इफ यू कैन टेक केयर ऑफ दैट साहित्य, देयर इज सम वॉइस लाइक ए थंडर, if you can take care of it. And it is done for the physiological function, and this is the operation which is being done 24/7 in a different and a diverse setting. Most common abdominal major surgery is being done, and it is always being evolved in the backdrop of women empowerment and reproductive and sexual rights. So right from the life-saving operation for mother, we have come to an era when every second or third mother is coming with a request for the cesarean section, and we are having backlash for the high incidence of cesarean section by the media and the government. However, WHO have revised its statement that every effort should be made to make available cesarean section any woman who needs cesarean section. And Foxy says that yes, every woman have the access, must have the access for the expectation of successful and safe vaginal delivery, along with need to intervene to the safe and a good cesarean section delivery to prevent morbidity and mortality. So the WHO statement that no cesarean section beyond 15%, actually it does not hold you. We will be having a lecture of Dr. Indira and Dr. Sandhya for having this statement, but this is important that every woman must have the access to the safe cesarean delivery. What we are concerned for all these indications, because the backlash is the economic cost, higher maternal morbidity, mortality, more perinatal morbidity can be there because more elective cesarean section, and the long-term complication, which I will be dealing about, which start from the caesarean scar defect and which can lead to a lot, complete spectrum of the placenta accreta. And we are still struggling with actually what are the diagnostic and the management modalities. So cesarean section is not just a cesarean section, and should always remain just cesarean section. And these are all new studies which shows that we can have more complication after cesarean section, a good number of re-laparotomies. So I will go to the first, the just immediate scar defect, and the sepsis is the most important issue which can cause the scar defect. We must have the risk assessment for our all laboring women. What was the duration of labor? What is that prolonged surgical time? It was a prolonged, it was done by whom? Instruments issue, nutritional status, anemia, obesity, and the comorbidities, especially the diabetes mellitus. We know we have to be very careful in diagnosing any degree of the wound infection, because even a simple looking wound infection can lead to necrotizing fasciitis and the other complication like the uterine artery erosion or the fistula. So a good diagnosis and a good protocol like giving swab culture sensitivity, appropriate antibiotic, good dressing, and whenever needed the surgical drainage. So important thing is that we know, but we want to prevent the wound, surgical wound infection after cesarean section. And for this, the most important thing is the right labor room practices. And second is the prophylactic intravenous antibiotic, which should be given at the time of cesarean section, and it should be given 30 to 60 minutes before skin incision. So don't put all patients together and the antibiotic given 2 hours before, or giving antibiotic after the delivery of baby is not that effective. A good antibiotic, usually the cephalosporin second generation or ampicillin and gentamicin, are fair enough, but timing of antibiotic and universal antibiotic prophylaxis is very, very important. If there has been the high risk factor like obesity in pre-surgical time, you can prolong the antibiotic to the oral for 5 days. If it is not, then the single antibiotic prophylaxis is very, very important and sufficient. We cannot go away with the universal safety precaution, good biomedical waste disposal. And important thing is that our cesarean section OTs might have the good all infection prevention practices, but our labor room must have that strict protocol for the sepsis prevention. No slippers allowed outside, good scrubbing, good washing, and a good vaginal examination technique that will help in reduction of the surgical site infection. Postpartum uterine dehiscence, they present to us as a refractory postpartum hemorrhage for which we are not identifying any cause. It can present to us as early as 10 days to 12 weeks after surgery, and the patient may come with the dysmenorrhea, irregular bleeding. And this is the important message I want to give to all audience, that the red flag sign for uterine dehiscence on ultrasound is the presence of bladder flap hematoma, large pelvic hematoma, presence of gas within uterine defect. And many times we share the cases, patient is having recurrent bleeding, ultrasound is normal. It is important that we look at the ultrasound in a different perspective and take notice of very, very small thing. So the cesarean scar defect is the most dreaded complication of cesarean scar, and they can present as the secondary postpartum hemorrhage as well as the mortality. Now, with the advent of color Doppler, we are seeing report of many times the AV malformation. So this is very important that we identify and diagnose the pseudoaneurysm and the AV malformation very, very properly. And we should consider the diagnosis of the uterine artery pseudoaneurysm in our differential diagnosis of the secondary postpartum hemorrhage. When you see this yin-yang flow, the turbulent flow, you have two things to do. You can, if the patient is stable, sometimes the arterial embolization can help. And sometimes when there is a patient is unstable, the hysterectomy is a quick and safe option. So these are the few pictures which shows about this pseudoaneurysm, and you can have the hypoechoic shadow. But if you do the color Doppler open, you see the turbulent, the moving blood flow around this, and it is a yin-yang sign. This is a turbulent flow, and that is a diagnostic of the pseudoaneurysm. After this, the immediate scar complication, the long-term scar complication can be the scar dehiscence, that is isthmocele, scar pregnancy, which can lead to the full spectrum of morbid adherent placenta spectrum. So what is this isthmocele or the post-cesarean niche? I will give few time to this, and this is considered like any prior uterine surgery, the severe cesarean scar defect is risk factor for all the late complications. So what is the etiopathogenesis of the placenta partita? It is the same deficiency of the deciduous placenta and the constitutional defect. These are there. And the terms used for this scar defect is isthmocele, cesarean scar defect, uterine dehiscence, and the diverticulum. It can be in a good number of the patient, and study says it may be around 30 to 60% patient after cesarean or uterine surgery can have the scar defect. If we use the transvaginal sonography, it is the diagnostic modality around 70%. If we add on with the sonohysterography, we can identify in more number of the patient. More number of cesarean section, more chances that the patient can have the scar niche. What can be the risk factor? That is the surgery related and the patient related, and how it is identified. So it is a triangular, irregular, oval, hypoechoic defect, which you see at the site of the cesarean scar, what we placed in the lower uterine segment. And when we are doing any transvaginal sonography, we must be very careful to look it, because normal cesarean scar just appear as a hypoechoic indented dot. What are the risk factors? So adhesion, retroflex uterus is an independent factor for the cesarean scar defect. Diabetes, high BMI, obesity, and the gestational diabetes. These are all risk factors because of the counter current force. Retroflex uterus is retroverted, blood supply to the uterine wound is hampered, and we can have more scar niche. Likewise, adhesion, they have the difficult, reduce that supply to the uterine wound and the less healing. So retroflex uterus is the independent factor, and the very, very important point which I wish to communicate. that elective cesarean section and the cesarean section in advanced labor are the situation where woman is more prone to have the cesarean scar defect, because the incision is not on the appropriate place, and that leads to inappropriate wound healing. Beside this, maternal age more than 35, increased number of cesarean section, increased number of induced abortion, and the place of cesarean section. So this is very important, because our government is now like work that every place, every PSC must have the cesarean section facility. And this is a very good paper from the China, who says that when the cesarean section is done at the rural community hospital, it is an independent factor for high incidence of cesarean scar pregnancy and the placenta accreta spectrum. And this is a very, very important key point, because many times the senior people say, including me, that no, we don't have the placenta accreta or defect after cesarean section, but when it is a low resource setting done by juniors, it can have an impact on the cesarean scar defect. So non-modifiable thing we cannot actually modify. So it is a age retroverted, we cannot modify. Labor related, that is a duration of labor more than 5 hours. And the modifiable risk factor are the surgical technique, where we put the incision, how we close the uterine incision, and when we do the cesarean section. In our gynae OPD, like think of the cesarean scar niche as a differential diagnosis. If she is coming with the post-menstrual spotting, she is coming again because the niche is obstructing menstrual blood flow. So first it is obstructed, then it is being released, and it is a painful menstruation. So in a gynae OPD, she can come with the prolonged bleeding, with the intermittent spotting, with the pain, with the mid-cycle intrauterine fluid accumulation, and the secondary infertility. And when you do the IVF, it is difficult to have the good embryo transfer, because it is like pushing not at the right place. We are not able to place the embryo at right place. It can also present as a bladder dysfunction and scar abscess. So one again important thing, when we are taking chronic pelvic pain today, the endometriosis is our first diagnosis. Now I say that keep the differential diagnosis of scar niche if the patient had the previous cesarean section. Now, this scar niche can lead to all scar pregnancy, placenta accreta, scar dehiscence, and the uterine rupture. And we have a very, very good paper right from our own country, Vidushi Garima Nuthan from AIMS, and from the international faculty. So it is this is again a very good paper from Indranil Datta, who says that scar niche, scar pregnancy, we are really missing out. And what we are having sudden life-threatening hemorrhage in our labor room, when the patient has taken either medical abortion or you are doing suction evacuation for a missed abortion, and suddenly you are encountering life-threatening hemorrhage, so that we have to be very, very careful in diagnosing before any complication occurs. It is a something life-saving issue in our clinical practice. So that is a hypoechoic indented area at the site of cesarean section, and we have to measure what is the residual biometrical thickness. If the residual biometrical thickness is very less, there are more and more chances that the patient can have the placenta accreta spectrum. This niche can be outward or inward. It can have concavity, abnormal vascularity. Sometimes it looks like polyp, and we have to supplement with a good TVS and the sonohysterography when there is some confusion. So this is important. And one again important point, if it is asymptomatic, incidentally diagnosed, patient is having no issue, you can ignore it. No treatment is needed. But if she is having abnormal uterine bleeding, COC can be effective, LNG IUCD not effective. But if she is having chronic pelvic pain, secondary infertility, AUB not responding to COC, then the surgical treatment is needed. That is resection by hysteroscopy, excision plus repair by transabdominal route, hysteroscopic niche resection if it is approachable from the below, niche repair, and sometimes hysterectomy. And Dr. Alka Kriplani has given, I have listened to her talks on a only comprehensive very variety of case what she is dealing with, which a patient is coming with a great large like a large size is garnished for the patient with the secondary infertility, for the patient with abnormal uterine bleeding. So it is very much around us, just it is we are not aware of it. So the subfertility, it is the indication for the treatment, and especially when the residual micrometrial thickness is less. So we can do it transabdominally, laparoscopically, or the hysteroscopy, though the learning curve is difficult because we don't have that amount of number of the cases. So primary prevention for this scar defect and the placenta partita spectrum is the minimizing primary cesarean section rate. And the secondary prevention is a good surgical technique in cesarean section because strong scar remains the mainstay in prevention of niche and the subsequent complication. So one thing important, what I have already said, that the timing of cesarean section. And when people say that we will do cesarean section when there is a onset of pain, they are very right actually, because in elective cesarean section, that is especially around 37 weeks, we put the incision too high. And when it is a advanced labor, we sometimes put the incision low, and that causes the poor wound healing. So the timing of cesarean section and the level of uterine incision is very, very important. And again, I emphasize that just doing cesarean closest to term and at the onset of labor is the best time to do the elective cesarean section. And this is the how it becomes like boy is when screening, you can take the research topic. We have a wonderful researcher over there that do the routine transvaginal ultrasound after 12 weeks of the cesarean section and see what is the incidence for the cesarean scar defect. So he is Atul Guade, and I have been pleasure of exchanging our books at Brazil FIGO conference. And I think I advise that everybody should read, every doctor should read the fiction which has been written by doctor. So checklist, complications, the simple adoption of checklist, which Dr. Atul Guade under the WHO have proposed, that simple a piece of paper can prevent 15 to 20% of surgical complication, and how a surgeon's mind works in the diverse setting when we do any surgery. So what is the standardization of cesarean section technique? Important thing is that every person has got its own idea, and we have a lot of research papers. So we are finding a forest for the tree. So many research papers that people are confused, that everybody thinks the junior resident, first year resident, and upcoming OB-GYN that I am doing right. And there is urgent need that the cesarean section technique should be standardized, because there are strong arguments. It improves safety, efficiency, effectiveness, and the training among OB-GYN residents should be more consistent so that we can have safety as well as we can have a good collection of data. So there has been a strong need for the standardization of surgical technique in the cesarean section, because the cesarean section surgery technique is a major public health issue. Actually, it has a public health impact. And these are the beautiful picture, few from the classical book and from my own book, that this is the standard cesarean section, how we put the incision and we don't remove. So few things I will say. The transverse incision is the incision for choice, no sharp dissection, the blunt subcutaneous and fascia expansion, blunt peritoneal entry, bladder flap development. It is again a gray area, because now few people say that omit bladder flap development, but it is usually desirable in most of the situation. Uterine incision and expansion is very, very important. So sharp 2 to 3 centimeter transverse incision, blunt entry, and the cephalocordate expansion. Placenta not to be removed, MRP, it has to be removed like spontaneously expelled out. Routine intrauterine wiping only recommended when you find that the placental membrane are adherent. Omit routine cervical dilatation. Uterine externalization is recommended. So uterine externalization, because many people are realistic that we always repair uterus in situ, but the standard technique proposed that it is better, safe and gives you added advantage. And the closer is the double layer non-locking suture. I will just emphasize on this very, very important the step which actually prevent the scar defect: omit intra-abdominal irrigation, omit visceral peritoneal closure, omit rectus muscle approximation, omit routine glove change, and rectus sheath continuous closure with delayed absorbable suture, and you can have the staple or subcuticular absorbable suture. So what I say, the uterine acceleration is safe because you can see the atonicity, you can massage, you can see the adnoxa. It gives you better access to see if there has been any injury or any damage. And the most important thing is, I will say one message, that 2-layer, double layer non-locking suture is the way which gives you the best uterine scar strength. So all studies actually emphasize we can have more complication, scar defect, placenta previta spectrum, silent uterine dehiscence in next pregnancy, and the double layer non-locking suture is far ahead, far better for the short term as well as the long term complication. And we have all the new studies. I'm putting all these studies so that you are confident in this. Don't use the locking suture. Very tight second layer suture can lead to ischemic necrosis. And we have to be very particular that we have myometrium to myometrium, endometrium to endometrium approximation. Another important finding, the message which our research have put, that once long ago we say that leave decidua, but now the research says it is better that we include the decidua in our suturing technique because it gives us the better uterine scar and the stronger scar. The good surgical technique, always the basic and principle that we have to take care of hemostasis, don't tissue handling, excessive tissue handling to be avoided. Tissue ischemia, too tight, too close suture are not to be used because that causes the less wound healing and due to the uterine ischemia. There are one or two new technique which has been proposed by few, and I will like to share. That is the modification of Misclave technique, and it shows that neither Phenestyl nor Zolcahan, you just follow the normal uterine skin, normal skin crease of the abdomen. You just give the uterine incision, the skin incision as per the size of the baby, and the closure of uterus again to the continuous suture, which are then knotted together. So these are the new technique which few people have proposed, that it can prevent the scar defect and the placenta previta spectrum, and it can give you the better uterine scar. So I'm just sharing that we few of us, especially who are in the teaching institution, can try it. And this is again a one technique which has been proposed, that is the 2-loop caudal to cephalic, and again the second loop from the close approximation, and 2 loops, and when you tie it gives the myometrium to myometrium, endometrium to endometrium, and the study says that it gives very good scar. So it is not the standards of cesarean section technique we have discussed, but these are the few things which has been proposed recently that it can have the better and the sound and the strong uterine scar. So finally, the surgeon does not believe in the talent. We believe in practice. We believe we are a people who are the curious egalitarians. So just to conclude my talk, that the cesarean scar defect, it is very much around us after cesarean section. We must be aware of it. It is good, like we do in our post-cesarean section ultrasound, and see what is the situation of the scar, whether the woman is having a scar niche or what degree of it is we are having. We can have to prevent, because a good surgical technique for the cesarean section, timing of cesarean section, good surgical practice, very, very good infection preventing practice can reduce the incidence of the immediate as well as the long-term scar complication, and we will have very less incidence or negligible incidence of the placenta previta spectrum. And the standardization of diagnosis and the management of scar defect is the need of the today's time, when we are having the cesarean section rate for the 35 to 40%. So with this, they say the world has become too complex for simple answers. They are wrong. This is time that across the region, and for all the reason you vote for a people, for a simplicity, for the straightness, for the commitment, and for the conviction. So remember that you vote for me when e-voting will start from 1st August to 10th August. And I have shared with you my vision, what I want to do, along with your help and your guidance, and taking your experience and expertise in every issue, so that we really do the work for making our independent India healthy and the very strong country. So thank you very much for the patient listening. And
Thank you very much, ma'am. Now I request our chairpersons, Dr. Ojaswani Patel, who is associate professor and project manager at Vimsar Burla, and Dr. Anju Singh, President Sitamarhi of Obs Gynae Society, Dr. Neelam Sinha, President Muzaffarpur Obs Gynae Society, for their valuable inputs. Dr. Ojaswani, are you there?
I am there.
Yeah, please.
So my namaskar to one and all. So at the outset, I'm thankful to Sadhana madam for giving me an opportunity to be the part of this great webinar. And as already described and discussed by my teacher Sindhu madam, that the cesarean section is going like anything. The rate in sometimes in the private center, it is around 90%. The private center is to the tune of 90%, as opposed to the WHO standard of only 15%. And even in our center, which is a medical college, the cesarean section rate is almost 60% compared to vaginal delivery, because it is a referral center. So anywhere, whether it is a private or government or anywhere, the cesarean section rate is alarmingly rising. And if this common procedure, if it is not properly done, definitely then we are facing this disaster situation in our day in and day out practice. Sometimes the morbid placenta adherence syndrome, it is a nightmare for the obstetrician, which is having a high mortality for the mother. And also so many complications, as Sadhana madam has discussed about the scar, niches, the isthmosil, the scar defect, so many complications. And madam has highlighted everything from the beginning to end, the pre-operative care, the intraoperative care, and the post-operative follow-up, so that how we can prevent this complication, this dreaded complication, we can get a smooth outcome of this cesarean section. Thank you, madam, for highlighting all the tips and tricks. Even I also in favor of doing cesarean section with uterus in situ. But from your advice, that I could know that we should do better with the uterus out, so that you can see the angles, we can massage, and you can know the different extents on all these things. Thank you, madam, for highlighting the cesarean section in details. Thank you, madam.
Thank you, Dr. Ojaswani. Dr. Neelam Sinha, ma'am, for your valuable inputs.
Yes, namaskar, madam. Dr. Sharna has elaborated everything, every point touches, and so beautifully that there is no anything left. One thing I like to highlight, it is the very important point that elaborated by the Dr. Sharna. Caesarean section must be performed after the normal labor has started. That is the most important from my side of it. This is the very important point, because the uterus is prepared for their good condition to operate.
Thank you so much, ma'am.
Actually, I will say now, Ojaswani is that extrusion. So it is nothing against extrusion, but if we take as a standard technique, it has got certain advantage and no disadvantage for all. And what Dr. Neelam says very rightly, that at onset of labor, if there is no other risk factor, that it prevents iatrogenic prematurity, we are able to give the incision at right place. It helps also in easy delivery. So advantages are many. Just we have to be ready for doing emergency cesarean section when the patient reaches us. So this is very important. So thank you.
One thing in today's scenario, it is very common. Madam, इस time पर ही मेरा seizure होना चाहिए. That is the astrologically, but I think it is not good. Normal, we wait for the start the labor. One thing, madam, I want to share with you, and I want to your advice. if we artificially start the labor, it is better to form a plant seizure.
Actually, if it is like elective cesarean, it is previous 1 or 2, and we are planned that it is cesarean, we don't think that it can be it can be risky. Actually, the way to communicate is just this point, that if we do Caesar in the advanced stage, or we do what is the today's practice, that yes, it is 36, 37 week now, it's okay. So that can give you the weak start, and it is better that we do cesarean section as close to labor. 38 to 39 week, it is good for everybody, and it is also for the prevention of scar defects.
No,
So
madam, no.
it is-
I want to.
So induction of labor, I can say that will not be feasible.
Induction of the labor is not.
Yes. If we are
Okay.
not ever going for the cesarean section, and we can have
Okay.
advice, like comment from our seniors as well. The party,
Just I want to know for this point.
To me, it is not feasible that we induce if we are planning elective cesarean section. And
Okay, thank you very much.
Thank you, madam. Thank you very much. Now I hand it over to my co-anchor, Dr. Maushmi Das.
Saiti, madam's presentation had come, Dr.
Yes, ma'am. Yes, ma'am. Both the
so-
presentations have come, and Dr. Maushmi will be conducting this. Dr. Maushmi, are you there? Please, I welcome Dr. Sandhya Rani Panigrahi, ma'am, to please start her talk. She'll be speaking on indications of this. Yeah, please, ma'am.
Now, madam. Good evening, everybody. Really, I am a blessed one to sharing my view and my slide and my knowledge with this amazing group of people. And really, regards to all my senior all over the country, and the doctors and colleagues from my state and outside, and dear friends. I am Dr. Sandhya Rani Panigrahi. I am assigned a topic of indication of caesarean section by Robson classification. Next slide, please. Caesarean section is really a major intervention for saving life of the woman and the newborn from the pregnancy and the childbirth related complication. Caesarean section rate is considering an important indicator for measuring obstetric service in any country, region, and institution. In many countries, based on the population, all cause of caesarean section rate have increased steadily during the past half century. The high and rising caesarean section rate is certainly a cause for concern. Next slide, please. The Robson classification system will help in analyzing the screening, auditing, and comparing the caesarean section rate across different hospital, countries, and regions. It is helped to create and implement effective strategic specification reached by WHO recommended caesarean rates. Caesarean section rate is an important indicator for measuring obstetric service in any country, region, and institution. WHO considered the acceptable rate of the caesarean section between 10 to 15%. The rate of caesarean section has increased beyond 15% in many countries all over the world and double in last decade. In my institution, the caesarean section rate, as it is a referral center, it is from 45 to 56%. When medically needed, caesarean section procedures can effectively prevent the maternal morbidity and fetal morbidity. Next slide, please.
Next slide. Saiti.
Next.
Hello,
Yes,
Saiti.
ma'am. I have changed it, ma'am. Yes, ma'am. I have changed the slide, ma'am.
Please do.
Caesarean delivery that continues to result in increased maternal mortality, maternal and infant mortality, and increased complication following deliveries, as well as increased need of finance, rising question about the appropriateness of the some caesarean section that may not be medically required. WHO emphasized every effort should be made to provide cesarean section to the women in need rather than striving to achieve a specific rate. Infant can enter this world in one of the two ways, either a vaginal birth or a C-section. But the ultimate target is to safely to give birth a healthy baby. Next slide, please. Above recommendation of increasing the cesarean section no longer associated with the recorded morbidity or mortality in both mother and the baby. Cesarean section is a surgical procedure associated with the short and long-term risks that can affect the woman's health and infant's health. In the last 3 decades, healthcare professionals, authorities, government, and the policymakers have conveyed their concern about the increased cesarean section rate and potential negative consequences for the health impact of the society. Next slide, please. WHO recommends that Robson classification is used as an appropriate C-section classification system. There is no significantly classification system to observe and compare cesarean rate. The Robson classification system will help analyzing, scientific auditing, and comparing the cesarean rates across different hospital, country, and region. It will help to create and implement effective strategies specifically to reach WHO recommended cesarean section rates. 10 group of Robson classification provide an easy way of gathering information about the cesarean section. Applying the classification help to identify the broad category of the pregnant women to undergo different cesarean section at the different time. And next slide, please. Statistics from 150 countries above the cesarean section whole world reaches 18.6 of the all world. Many European countries have, these are the all statistics. European countries have emerged the control of reduced cesarean section rate over a period of time. Countries like Norway and Finland have the cesarean section rate about 15%. The lowest is in the South Africa, they were in 7.3%. Next slide, please. The OECD explained this reason of increased cesarean section as follows: increased nulliparous older women, multiple pregnancy as a rate of assisted reproductive technology, timely management of both doctors and the patient. Next slide, please. Physicians are able to influence the choice of delivery method because they have better information than patient about the physiology and possible complication. Liver physician induce demand theory that predicts that it is possible to improve the cesarean resistance by the setting of area of intervention, acting the direction of the guidance, depending on the Robson criteria. Next slide, please. The Robson criteria classify all delivery into 10 groups on the basis of 5 parameters: that parity, the onset of the labor, fetal presentation, number of gestation, number of fetuses, gestational age. Next slide, please. The WHO has proposed the Robson classification as an international standard. Thus, it may be possible to monitor the changes. Robson classification used over 33 million pregnancy in 31 countries following WHO recommendation. Next slide. The Robson grouping of system in cesarean delivery. The Robson 1 classification includes nulliparous, single cephalic, gestational is more than 37 weeks, spontaneous labor. Robson 2 is nulliparous, single cephalic, more than 37 weeks, induced. Robson 3 classification is multiple pregnancy, means multipara with previous cesarean section. Next slide. Robson 4 is multipara, including previous cesarean section, single cephalic, more than 37 weeks, induced. Robson 5 is previous cesarean, single cephalic, more than 37, equal to 37 or more than 37 weeks of gestation. Robson 6 is all nulliparous breaches. Robson 7 is all multiparous with breached presentation, including previous cesarean section. Robson 8 is all multiple pregnancy, including previous cesarean section. Robson 9 is all abnormal line, including previous cesarean section. Robson 10 is all pregnancy below 36 weeks, including previous cesarean section. Next slide, please. Induction of labor is an artificial initiation of labor before its spontaneous onset of delivery to the placental unit. It is different from the stimulating a labor that is demonstrates slow labor progress. According to WHO, any method of induction is valid, including amniotomy, misoprostol, oxytocin, intracervical Foley's catheter, or other. Women who enter labor spontaneously and other receive uterotonic agents, have an amniotomy or correct dystosis or to stimulate labor develop, belong to the induced group, and they are classified as the spontaneous onset of labor group. Next slide, please. Pregnant women are grouped within the Robson classification according to the WHO guideline. Studies also done relationship between the Robson group and the hospital type, either public or the private. Study material and data were obtained from the open source the MOH. Next slide. So that is my discussion. The high and the rising cesarean section rate is certainly for the concern, and evidence is needed about how and why the cesarean section rate has increased and what need to be done. It is to be demonstrated that the Robson classification can be used as a common starting point for the cesarean section delivery and the audit. It is a comparison of the cesarean section rate in healthcare facilities using the Robson classification, and they found that cesarean section increase in which group of over time. Once a cesarean, always a cesarean, not holds good everywhere or all times. Increased rate also because the late marriage, highly educated group and sophisticated affluent society desire for elective cesarean section in as a Murta case, and the insurance company other group also facilitated for this one. Thank you everybody. Really sorry for my inconvenience to all one. Sorry. Thank you.
Yeah, thank you, Madam Dr. Sandhya Rani Panigrahi, for a very short and crisp presentation. So we're coming up with the next speaker, Dr. Indira Palo. The topic is cesarean section audit, need of the hour.
Hello. Good evening.
Yes,
to
Dr.
all of
Indira.
you. Am I audible?
Yes, you are audible.
My slides are visible.
Yes, Madam, please continue.
Thank you, Sadhana Madam, and all the team who are working behind the scene. Thank you, Mosim Madam. So all of us know that the cesarean section rate is increasing, and either this is the need of the hour that we should introspect ourselves and we'll do a cesarean success audit. Is it necessary? So we'll go through the slides. Next slide, Madam. The International Health Agency, that is WHO, has in 1985 recommended that the rate of cesarean section ideal is the only 10 to 15%. Everybody is talking about the 10 to 15%. But what it is exactly? It is not your institution. It is the geographical area. Suppose I am residing in the southern part of Odisha, so it is the geographical area where this cesarean section is countable. It is 10 to 15% is there or not. So it is not your own hospital or a public hospital or a private hospital. It is not counting. It is counting the geographical area where this cesarean section rate is how much. So it has been increasing commonly both in developed and developing countries. There is no evidence that there is any benefit for cesarean delivery for women or infants who do not require the procedure. As with any surgery, it is associated with short and long-term risks. Today, we have just listened to Sadhana Madam that the incidence of cesarean scan pregnancy and placenta ectasia spectrum disease also increasing due to this high cesarean section rate. Next. So what exactly WHO recommends? In 1985, the WHO does not recommend to go for a specific rate. There is no specific rate for countries to achieve at a population rate. It has been found by the WHO that countries increase their cesarean rate up to 10%, maternal and neonatal mortality decreases. But if the cesarean section higher than 10%, it has been seen that it is not associated in reduction in maternal or neonatal mortality rates. So it has also apart from mortality, short and long-term maternal and prenatal morbidity and mortality. Apart from the psychosocial implication regarding the maternal health, infant relation is there. So at present, do we really need a C-section audit? The answer is a big yes. Next. I have gone through the literature by Nivetha Roy. What is the changing scenario of cesarean section delivery in India? Understanding the maternal health concern and its associated predator by observing the National Family Health Services Data 3 Tata 4 and NHS 5. So in what he found in his the changing scenario, we'll go through this. Next. So if you go through this cesarean trends by National Family Health Service 3, 4, 5, it was in between 2005-6 NFHS 3 shows that the cesarean section rate in India is 8.5%. The recent trend is 21.5% is there. So there has been increase in 13% increase in cesarean section rate in India within this decade, 2 decades. Next. So if you go through the which state we are having highest cesarean, it is the Telangana. It is having highest cesarean section in the 60.7%, and the lowest cesarean section rate is in the Bihar. That is only 9.77. So I also there is in Nagaland also it is having very high low rate. It is 5.2. So Nagaland is having very lowest cesarean section, that is 5.2, and Telangana is having highest cesarean section. It is 60.7. Next. So we have the white areas that do not have, we have not received the data, but whatever data we have received, it is, if you compare in National Family Health Service 4 and 5, there is in the southern part of Odisha, there is highest cesarean section rate, and we actually do not have the data in, it is in the upper part, northern part, and also Nagaland, there is lowest, that is around less than 10% is there. Next. So we all obstetricians know what is the common reasons for obstetric indication. But I'll share some of the non-obstetric reasons of high cesarean section because of fear of pain. All the literate women, they fear that labor is a very painful condition, so they avoid pain. Many believe that cesarean section is a less traumatic than the cesarean section. And also many families, they find an auspicious day for the delivery so that the baby will born a lucky born. There is a suitable time and date and time for the healthcare professionals also, and also the family members, because the healthcare professionals may not be available in the night time. So they choose the date and date of the birth due to believe that the luck is favor in that period if you deliver. And also there is societal pressure for a perfect birth outcome. People expect that there should be a perfect birth outcome, and that is a main reason behind it. Health professional, they switch over to cesarean section to avoid the litigation. And many women, they through the Google search, they think that if they will go for cesarean section, they will preserve their pelvic floor anatomy, and there will less chance of urinary condition, and they will satisfactorily return to the sexual life after delivery. So these are the common non-obstetric reasons that we find that is the reason for a high cesarean section in our society nowadays. Next. So what we actually need, we have seen the more the literate women, the more the cesarean section rate. So we don't want that literacy is proportionate to the cesarean section, but we need a maternal health literacy among women. What exactly we want to teach the women that they should have rising awareness on the importance of normal deliveries for healthy pregnant mothers. Those who are having some complications, yes, it is okay. But who can do this? The person who is the frontline worker, who are the frontline ASA, Anganwadi, the community health workers, and the primary care physician, who are at the first point of contact for the pregnant mother for antenatal care, checkup, and any health problem, they come to these people. They should counsel them that they should the process of the delivery, they should counsel them so that they will be mentally prepared for the delivery, so that the unnecessary immediate cesarean section of fear due to fear that can be avoided during the checkups, the delivery and their medical improvements, so that they make themselves prepared for the labor, and incidence of sudden decision should be reduced in the future. It is crucial to formulate a mandate where it should be noted that cesarean delivery should be done by the health professional in which place. Next. So what is the trend in Odisha and in India? I am belonging to Odisha. So if you compare NHS 4 and 5, it was only 13.8 in between 2015, and now the cesarean section rate in Odisha is more than what is the national average, that is 21.5. So it is now the India is more advanced in that way. Next. So if you go to NHS 4 and 5 in the public and private sector, it is in during 2005 and 6, it was only in public, it was 15%, 11%, and private is 15%. Now it is, if you go to NHS 5, in private sector, the cesarean section rate is 70%. I know, I am also a practitioner. We do not allow a person who we think who is going to deliver vaginally. We are not allowing go to the private. We are allowing them to go for a public service. You know, that is the reason. But thing is that it is very high than what is actually the cesarean section trend in Odisha, in India. If you compare the cesarean section trend in India, it is in private is 47.4, where if you see that in private in Odisha it is 70%. So that is the reason, that is the headache of this government, that how we can curb this high trend in the Odisha. Next. Next slide. So rising cesarean section rate is a cause of concern, as evident from recent NHS 5 findings. In India, the rate of cesarean section has increased from 17% to 21%, but in private section, the health facility is 70.7% out of all deliveries in private health facility, which has increased from 53% to 70%, and from NHS 5 to NFHS 5. It is important to ensure that the cesarean section are undertaken judiciously, only cases with robust clinical indication. In order to audit indications for cesarean section and improve decision making and obstetric management, these C-section audit formats are essential. In 1985, a panel of WHO reproductive health experts stated that there is no justification for any region to have C-section rate higher than 10 to 15% of all deliveries. I just repeat that 10 to 15% for a geographical area, not a particular health facility. In 2015, the WHO re-examined the available evidence and stated that at population level. So these incidents, the WHO is planning for population level, not a hospital, not a private or public hospital. And rates higher than 10% are not associated in reduction in maternal and newborn mortality. This shows there is immediate need to curb the incidence of this cesarean section. Next. Next. So the theme of 2023 is the promote women-centered care and reduce unnecessary cesarean section. This is the theme of this year UNICEF, and so that we also adopt to this this theme, we should promote our women-centered care and we should try to reduce our unnecessary cesarean section. Next. So if I'll go through the what is the cesarean section in different districts of Odisha, the highest incidence is in Jagatsinghpur in public health facility. And
Dr. Indira Palo, just request you to wind up because we are exceeding the time.
Okay. It is
5.50%.
Okay. So next. So there has been audit format has come from the government of Odisha for the public as well as the private sector. Next. This is for the private and both for the public sector. Next. So the objective to implement such an audit at facility level, so that the cesarean section, everyone who does the cesarean section has to fill up the format is given to us, both in public and private, and we are filling after the delivery. Next. And this will be deposited or forwarded to the center government health services, and that will be there will be audit at the end of the month. So everyone who is conducting both in private and public should fill up the audit form, and it will send to the higher authority. Next. So the person who is conducting this surgery should personally fill up the form. He may be a PG, MCS or DNB, whatever may be the qualification, she should fill up the form. Next. So the flow of data that all formats will go district, then it will state, and there will be RCH meeting will be there at the end of the every month. Next. based on the evaluator using internal assessment methods to assess the evidence with most appropriate analytic technique, WHO concludes that next cesarean section is a effective life-saving measure, but at population level it should be less than 10%. It has been seen that if the rate is more than 10%, it does not decrease the maternal and neonatal healthcare mortality and morbidity. Every effort should be made to provide cesarean section to women in need rather than striving to achieve a specific rate of less than 15%. Next. Thank you all.
Thank you, Madam Dr. Indira Palo, for a very wonderful presentation and much needed presentation. Of course, cesarean section audit has to be done in every labor room. I request our chairpersons to give in their comments for this. Dr. Sudha Jha, Madam.
Thank you, ma'am. Such a elaborate, am I audible?
Yes, Madam, please.
Such a elaborate discussion for the audit of cesarean section. In public sector, there is a protocol to audit the cesarean section to curb the unnecessary cesarean section. But we should also concern where you are sitting. If you are sitting in a hospital which is quaternary or tertiary referral unit, then the patient comes there only after the much trial of normal delivery, obstetric level, or any such cases that needs cesarean section. So in that cases, the rate of cesarean section is a bit higher, but much more higher should be curved, and the audit which is in public sector should also be in the private sector. So it is not recommended, because even if in good hands with all facilities, the mortality and morbidity rate after cesarean section is higher than normal vaginal delivery. Thank you.
Thank you, Madam. Dr. Stuti Khare.
Yes, can you hear me?
Yes, please, Madam. Please come in.
Okay, good evening. And thanks to Dr. Palo and Dr. Sandhya Rani for a very good presentation. And but here, you know, as a senior consultant, I would like to, I won't say warn, but I would like to take the younger generation to not do cesarean section for a simple IUD now, what I see. Intrauterine fetal death, until unless it has an obstetrical factor like placenta previa or big baby or severe preeclampsia, I think it should not be done, which I am facing, or I am seeing this as a common finding nowadays. Patients coming with a previous cesarean on a dead fetus. And definitely in the urban areas, the people are more educated, and the girls, their choice is that a cesarean would be a safe delivery, and they want a cesarean delivery where the mother-in-law, of course, plays a very important role in motivating her to get a normal delivery done. But the husband and wife definitely need a more push for going for a normal vaginal delivery. Thank you very much.
Dr. Dilip is with us. Dr. Dilip Sarangi is last comment. Unmute.
Surgery and come back. Thank you. I just missed Sandhya Madam's talk, but Palo has done exceptionally well. Indira Madam, as always, she does very well. I missed the later part of the Sandhya Madam's talk. But however, the total scenario is cesarean section rate is increasing, and all are concerned, from patients to their attendant to people at large and media, everybody and government. And lately, our obstetrician also, we are becoming little increasingly aware that the cesarean section rate is increasing quite a bit, along with the complications, as Madam has already pointed out in our talk, is also increasing. So decrease this in all level, we must try. And that's why all these Robson's criteria are coming out, and the cesarean section audit is cesarean section audit is still there since a long in government sector. About a year or so we are doing in Odisha, And naturally, if you look into all these things, cesarean section, primary cesarean section rate will decrease, and subsequent the complications of cesarean section will also decrease. It will be better for all of us as well as for the mothers. Thank you very much. Thank you, Indra and Sandhya ma'am.
Yeah, thank you, sir. So now winding up this first session, we now move directly to the session 3, which is on post-cesarean care and complications. This speaker is a very young, dynamic speaker, Dr. Prithviraj Sethi from Bhubaneswar. I welcome the 3 chairpersons we have with us, Dr. Brajakishore. He is the retired Special Secretary Health, Government of Odisha, life member of FOXI, IMA and FMS, consultant gynecologist, Amit Hospital, Barampur, with a special interest in high-risk pregnancy and infertility. Dr. Kamal Prasad Agarwal, he is the teaching faculty in High-Tech Medical College, Rourkela, and consultant, Lifeline Hospital, Rourkela, trained in ultrasound, laparoscopy, infertility, and reproductive genetics. We have Dr. Prachi Singh with us. She is the East Zone Coordinator of Imaging Science Committee, FOXI 2018, Founder Secretary, ISOPAB Muzaffarpur, Joint Secretary of Muzaffarpur Obs and Gynae Society, and Secretary of IMA Muzaffarpur 2019. So may I request Dr. Brajakishore, sir, to please introduce the speaker, Dr. Prithviraj Sethi. Dr. Brajakishore.
Very much good evening to all of you. I am very much thankful to Mousumi Madam, especially Sadhana Madam, Mousumi Madam, and Indra Madam to give me a chance to speak in this, to be a chairperson in this very grand CS conclave. I have the honor duty given to introduce Dr. Prithviraj Sethi. He is additional professor in OG in AIMS Bhubaneswar, the prestigious institution of the Odisha. He is affiliated members of FOXI, life member of NATSI, member of ISOPAR. He has got award in fellowship in ICOG, FIC, MCH, and FIA-OG. There is a lot of publications, oral presentations. He has given a lot of things. And he was examiner for MBBS and postgraduate students. His special interest in gynec endoscopy, infertility, high-risk pregnancy. I welcome Dr. Prithviraj Sethi to speak on this post-operative management and complications in cesarean section.
Thank you, sir. Brajakishore, sir. At the outset, I will thank Sadhana Madam, Ojosini Madam, Gangadhar Sahu, sir. He is my teacher. Gangadhar Sahu, sir, is my teacher. Yeah. So, my topic is post-cesarean care and complications. Next slide. Next slide, please. Next slide, please. So I am from Odisha, and you may be remembering a few days back, there was a train tragedy. So it was a complication, though the India is known for running so many trains. So similarly, we are doing so many cesarean section, and there can be some complication, and we should anticipate complication, and that's how we should proceed, and we can manage it. Next slide, please. So I will deal with complication trans-surgical, that is intraoperative, and post-surgical, maybe early and late. Next slide. So trans-surgical complication, the most common complication is the hemorrhage or postpartum hemorrhage. Around 75% of cases of postpartum hemorrhage, obstetric hemorrhage occur in cesarean section. And in developing countries, this hemorrhage and eclampsia or preeclampsia, they usually take first or second position alternatively in case for maternal mortality. And as you know, the accepted amount of bleeding during cesarean section is 1 liter. Next slide. So before going for a cesarean section, you should anticipate any hemorrhage, and there's some risk factor you should think about the placenta acquita syndrome. Sadhana Madam already told you in details. Most common is uterine atony, and in case of overdistension of the uterus, in case of multiparity, multiple pregnancy, polyhydramnios, and if there is fetal macrosomia, if there is prolonged labor, if there is chorioamnitis and obesity. So the risk increases in these cases. Next slide. So this management everybody will be knowing, because so many times this PPS drill usually done. So first aim is to go for volume replacement and usually blood transfusion, and the medical management by oxytocin, ergometrin, carbetocin, misoprostol, and tranexamine. So these are the drugs that should be available in your labor room. Next slide, please. Then we go for surgical management if the medical management fails. So Billy sutures, other sutures for complex sutures are available, and stepwise devascularization of the uterine artery, ovarian artery, then hypoplastic artery, and at last we may land in hysterectomy. So I am purposefully skipping these things because everybody will be knowing this one. Next slide, please. The problem in cesarean section, usually we are afraid of this type of injury, that is urological injury. Though the bladder is the neighbor to the uterus, but most of the obstetricians are afraid of the bladder. So sometimes in case of previous cesarean section, in case of previous, if there is any history of myomectomy, if there is any other operation for any intra-abdominal organ pathology, in those cases, chances of bladder injury is more. So bladder laceration rate is around 2 in 1,000 cesarean delivery, and the ureteral trauma is 0.3 in 1,000 cases. Next slide, please. So the bladder laceration usually most commonly occurs during dissection of vesico-uterine space, and when you go for entry to the peritoneal cavities, and during hysterectomy. So emergency in case of morbid organ, in case of during stage of labor, like in obstetric labor, and if you are doing cesarean hysterectomy, and most of the time during cesarean hysterectomy, this bladder injury usually occurs. Next slide, please. So usually detection of bladder injury by seeing the Foley's bulb, if there is clear fluid that is gushing out from the injury site, and if in suspected case sometimes there will be hematuria and you cannot see the injury properly. So in that case, retrograde insertion of methylene blue can be done, and most of the time the dome is lacerated and followed by the trigone injury. And usually, if availability of urologic surgeon is not there, then you can do this suturing the bladder repair by 3-0 observable suture or non-observable suture with double closure. And again, you have to see for any leakage of the urine by again retrograde instillation of either methylene blue or normal saline. Next slide, please. So sometimes it is not recognized, that then you may have to go for retrograde urography and CT scan. These patients, they usually complain of post-operative hematuria, there may be oliguria and abdominal pain or flank pain, and sometimes they may develop peritonitis or fever, and sometimes they present with fistula. Next slide, please. And coming to ureteric injury, so ureteric injury, though they are uncommon, but especially in case of obstetric hysterectomy and in case of placenta accreta syndrome, if there is any extension of hysterectomy wound to the broad ligament and vagina, in those cases, chances of ureteric injury will be there. And if you are suspecting ureteric injury, then you have to go for cystoscopy. You see for the urine flow in the bladder, and then if you are not sure, then you can go for IV methylene blue or IV sodium fluorescein. Is a dye that can be given IV, and you can see for the jet of this urine flow through the ureter. And then you can go for insertion of ureteric catheter. Next slide, please. So sometimes if you are introducing this ureteric catheter, if there is a failure to advance, then you may be thinking that ureteric thinking is there, or if there may be some ligation. And sometimes you can see the ureteric catheter popping through this injury site. And in those cases, again, you have to go for repair. Next slide, please. So there are various methods. So ureterostomy or psoas hitch or Boary flap can be given. Next slide, please. Next, that though it is again uncommon, but it can happen in case of previous cesarean section and you are attempting cesarean section next time. Then in those cases again, chances of barbed injury will be there. And I want to tell that if there is aerosol, it should be repaired with either observable or non-observable sutures. Otherwise, these aerosol tear are the weak points, and post-operatively they can they may perforate and they may lead to peritonitis. Next slide, please. Anesthetic complication, everybody will be knowing about the regional anesthetic complication. There is hypotension. If there is high spinal, they may advise to respiratory arrest. In case of obese patient, it may be difficult airway, and sometimes due to gastric, in general anesthesia, there may be aspiration of gastric content, and it can lead to chemical pneumonitis. So these are common anesthetic complications. Next slide, please. Next slide. Next common complication is infection. In fact, this postpartum endometritis is 5 to 20 times more common than the vaginal delivery. And it is mainly due to manipulation and sometimes due to instrumental contamination. And if you are giving sutures that are more tight and tissue necrosis. And usually the most common organisms are aerobic gram-positive cocci and gram-positive anaerobic bacilli. Next slide, please. And they usually diagnosed by fever, foul-smelling lochia, uterine tenderness will be there, and lab test there will be leukocytosis, and usually third generation will be sufficient. Next slide, please. And common is again urinary tract infection because of catheter insertion, and sometimes you may have seen this surgical site infection because most of the time subcutaneous sutures metal is usually given, but if there is collection of this fluid, then it can lead to the surgical site infection. And in other cases also, like suppose there is any history of chorioamnitis, if the history of leaking, then in those cases also the surgical site infection are common, and especially in case of diabetic mother also the surgical site infection are common. Next slide, please. Another thing is thromboembolism, though it is rare and sometimes patient may die with pulmonary embolism, and they usually perish tachycardia, dyspnea, malaise, and severe chest pain. And if you have to encounter with this thromboembolism, then you have to go for some investigation to localize whether there is any pulmonary embolism or there or not, and the anticoagulation, that is the unfractionated treatment of choice. And most of the time in obese patient, and if there is history of any venous thromboembolism, in those cases also venous thromboembolism is common. Next slide, please. Fetal complication, usually we forget to note the fetal complication during cesarean section, because most of the time patients are really they do not, or they rely for vaginal delivery, but even if you tell them that there is chances of complication to the mother, but they do not think about the fetal complication. Fetal complication also can happen, and especially if there is malpresentation, and sometimes there may be incidents of scalpel injury to the fetal skull, and chances of respiratory stress syndrome is more common in cesarean section than the vaginal delivery. Next slide, please. So late post-surgical complication, there may be endometriosis of the abdominal scar or scar endometriosis. There may be placenta accreta and nutrient absorption in later pregnancy. There may be adhesion, incisional hernia, and scar ectopy. Next slide, please. Coming to the post-operative care. So usually the post-operative care, usually we give start from the 0 day and usually up to 7 days. And the first thing within 24 hours, usually first thing is to have the fluid replacement. So as the surgery guideline, they usually tell you have to go for replacement. So best lactate ringer or RL, and you can give similar crystal solution with 5% dextrose. And you should estimate blood loss, so specifically within first 1 hour. That is the golden hour. So you should estimate the blood loss. Next slide, please.
Dr. Sethi, just 3 minutes left.
Another 3 to 4 minutes, madam.
Yes.
Okay.
Yes.
Usually, you have to monitor the vaginal bleeding in the first hour. You have to get, and you have to see for contact or not. Next slide, please. Analysis paracetamol, NSAID, and sometimes though it causes respiratory distress, respiratory depression, but it can help in analgesic. Next slide, please. Again, monitoring for the vital sign, urine tone, urine output, and hematocrit estimation. Next slide, please. Next slide. This is important. Usually, this usually as obstetrician usually forget for some analysis, but as per the American College of Obstetrician and Gynecology, all women should have this mechanical prophylaxis with use of pneumatic sequential compression device, okay? And that should be continued until patient is ambulatory. So usually we should patient to make ambulation as soon as possible. Next slide, please. And for prophylaxis, you can give enoxaparin, milligrams of frequency once a day. Next slide. And next slide. And the breastfeeding, that should be started from the delivery. In fact, it should be started during cesarean section. While closing the uterus, the baby should be on the breast of the mother. Okay. And this bladder and bowel function, usually we should start the oral liquid or solid diet just a few hours after the surgery, and usually it causes increased gastrocolic reflex and chances of this ileocytosis. And some people, they prefer to advise this gum chewing of gum for at least 3 times per day, 15 to 20 minutes. And if there is, if you are suspecting this ileus, then you should go for CT abdomen or abdominal chest X-ray. Next slide, please. Next slide. Next slide. Ambulation is important. Next slide. Okay. So usually the sutures to be removed either 6th or 7th day, and hospital discharge, usually you can, in non-complete cesarean delivery, you can discharge the patient within 3 to 4 days. Okay. So next slide. So to conclude my topic, the best way to prevent complication in cesarean section is not to indicate an unnecessary one. So without any indication, do not proceed for any cesarean section. And more the cesarean section, more complication will be there. And if you are having careful management of tissue, the tissue will respect. So I remember our teacher, Dr. Gangadhar Sahu, he always tells me that you respect the tissue. So tissue should be respected so that the chances of complication will be less. Thank you.
Thank you, Dr. Sethi. It was really a wonderful presentation. I invite comments and from Dr. Kamal Prasad Agarwal, our chairperson.
First of all, I am audible. Am I audible?
Yes, sir, please.
Yes.
First of all, I thank Sadhana Gupta madam, our future president, and very good presentation by our Dr. Sethi. It is said, true obstetrics is a great art, and because it is a difficult art, it is easier to become a caesareist than a good obstetrician. But nothing is without complication, and Dr. Sethi had presented very well, mainly from, I think, William Obstetrics, that prediction, prevention, and recognition and management beautifully. I thank him very much.
Hello.
Thank you, sir.
Dr. Mosmi,
Yes, madam.
I'm Dr. Prachi Singh.
Yes, yes.
I would like to
Yes,
say a few
please.
comments.
Yeah.
First of all, I want to thank Dr. Sadhana Gupta madam for inviting me to this very nice CME and very important CME. I think Dr. Shetty has done a very good job. You have covered all aspects of cesarean. Just one point which I find is very important, and many of people might not be aware of this fact, that this PPH cannula, this is very important and it is very useful in cases of atonic PPH. In cases of cesarean section, if the cervix is dilated at least one finger, we can insert the PPH cannula if there is atonic PPH, and it really works. Even today also, I had a case of prolonged labor. Ultimately, I had to do a cesarean, and patient went into PPH and I inserted the cannula, and I'm quite happy. For some minutes, the blood comes and then the uterus just contracts over the cannula. So this is my experience. I want to share with you all that in atonic PPH, please do try this cannula. Otherwise, thank you very much. And it was a
Actually,
nice...
what is a very important comment from you, and actually in PPH workshop, we are having a large series of this skill and drill PPH workshop, and Dr. Samartha Ram is actually is our constant faculty, and he's showing video, and it is our thing that this PPH cannula must be available at all settings. This is a very, very low cost measure and almost always effective in atonic PPH. So thank you for sharing it, because you have actually added to our mission that we must have confidence in our innovation, and very, very simple thing what we have. And thank you for sharing your experience.
Thank you, madam. It is very useful. Those who have not tried it must keep it.
Thank you.
Thank you. Our chairpersons, Dr. Brajakishore sir, Dr. Kamal Prasad Agarwal, and Dr. Prachi Singh, and our speaker, Dr. Prithviraj Sethi. So we now move ahead to the panel discussion.
We recognize 1 minute, Dr. Gangadhar Sahu is with us. And once our panel is over, we will like to have his comment if he is there. So Madam Sir is there, Dr. Gangadhar Sahu. Thank you very much for being with us. And or at the same time, at this moment, you, Dr. Gangadhar Sahu, because Dr. Prithvi was your student now, so we can have your short comment.
Sure. So should I tell now or after the panel discussion?
What do you think? If it is okay, whatever is convenient for you.
It is convenient after all your scheduled program is over.
Yes. So Mashmi, you.
Yes, madam. Sir has been there right from the beginning. So we have 8 panelists with us. Dr. Sujata Kumari. We can have the CVs of the panelists. So the moderator of the panel is Dr. Sadhana Gupta, the expert today. Co-moderated by me, Dr. Moushami Das Ghosh from Jamshedpur. I work in Tata Main Hospital. The panelists, Dr. Sujata Kumari. She's an IVF consultant and laparoscopic surgeon from Rourkela and life member of ISOPAR. She is the secretary of Rourkela Obstetric and Gynae Society. Dr. Piyush Bansal. He is a former research officer from AIMS and now working in Rourkela in JP Hospital and Research Center. Dr. S.J. Patel, Dr. Shankar Jaikishan Patel. He is the director and senior consultant of Jagniyasani Hospital, Jharsuguda, Odisha. Trained in IVF from Singapore, fetal medicine from Switzerland, and urogynecology from Cyprus. Then we have Dr. Renuka Sahu. She is working in Basundhara Maternity Home, Sambalpur, Odisha, and she's a life member of FOXY, ISOPAV, and IMA. Dr. Jyoti Das from Muzaffarpur. She's the professor in Jamuhar, consultant in obstetrician, executive member of IAGES, and president of Janak Foundation. We have Dr. Rashi. She's a consultant obstetrician, gynecologist, infertility specialist, laparoscopic surgeon from Muzaffarpur. We have Dr. Roniyar Kanchan. She is working in Sitamarhi in Shyam Childcare and Maternity Center, Sitamarhi Obs and Gynae Society. Next, Dr. Nivedita Bharti. She is working in Neel Madhuri Maternity Hospital, Sitamarhi. So as you can see, we have 8 expert panelists from Burla, Rourkela, Sambalpur, Muzaffarpur, Sitamarhi. So we will have a varied inputs from all specialities and all places. So we begin with the presentation.
I'm sharing. So we are here to deal with the difficult situation and surprises in cesarean section, and me and Rosmi will be taking along few cases. What is we encounter very commonly. So a warm welcome to Dr. Sujata, Piyush, Dr. Patel, Dr. Renuka, Jyoti, Dr. Rashi, Dr. Ronyar, and Dr. Nivedita Bharti. So we have all done. We are talking about the cesarean section and the difficult situation. But before for the difficult situation, let's yes. So just to get ready our battlefield very equipped. So Dr. Sujata, we will take 1 or 2 questions which makes our battlefield strong when we are doing cesarean section. So your choice of anesthesia in cesarean section. Dr. Sujata.
Very good evening, ma'am. First of all, am I audible?
Yes.
Yes. First of all, thank you, Dr. Sadhana ma'am, for inviting me as a panelist. I am grateful to you. Now, regarding the question of this panel discussion, I generally prefer to go for the spinal anesthesia for the cesarean section, because relaxation is good. And if there is general anesthesia, then we have the tension to deliver the baby as early as possible, and even the effect of the general anesthesia medication can go to the baby. So I personally and generally prefer for the spinal anesthesia is better. Would like to have your opinion.
So thank you, Sujata, for being so earnest. Rightly, the regional anesthesia is the anesthesia of choice. It has the maternal advantage, fetal advantage, less complication rate, and all the things. Actually, if you are using general anesthesia, the indication must be documented, that why we are using general anesthesia. That may be the back problem, but there are certain situations when we need to have the general anesthesia. One is the hemodynamic instability. If the patient is unstable, patient is severely anemic, she is hypotension before giving spinal or the regional, that is the time we should think of the general anesthesia and the anticoagulopathy. So what is the anesthetist recommendation? That platelet count must be above 80,000. If it is less than 80,000, then one should opt for the general anesthesia. And the back issue, and sometimes the patient consent. Patient does not want spinal or the regional. So there are few. So of course, Sujata was very right. We all obstetricians like it because there is no pressure to deliver the baby, and this is our part. But one message is very important, that even we are doing around 98% of cesarean in spinal or epidural, we always have the very equipped operation theater, so that whenever there is need arise, we can very quickly change to the general anesthesia. Because so many times, I say please, Sahiti, kindly mute the thing. Doctor, yes. So this is very important, that regional anesthesia is the anesthesia of choice. We must know what are the indication for the general anesthesia. Patient request is also one of them, and the need for it. And the third thing is that whatever is the situation, because what we are discussing are unpredictable situation, and there is a sudden need to switch into the general anesthesia, like the post-spinal acute drop in the blood pressure and the pulse. So it is some of the thing when we really need the resuscitation. So this is very important that don't go and do cesarean section in that OT where we don't have all boys trolley and the all cylinders and the general anesthesia equipment. One question to all panel that do for the cesarean section, do we have all pre-anesthetic checkup, or in cesarean we are just omitting it? Sujata, your comment or anybody's will add. Are we doing pre-anesthetic?
So, ma'am, ideally it should be done, but yes, I am very true that it's not being done. But yes, we are doing all the pre-op investigation rightly, from coagulation profile to everything before going for the cesarean section.
So this is actually, yes, anybody want to add for the ground realities?
In
Yes.
our situation,
Yes, Dr.
if the
Patel, yes.
patient is in a risk, high risk factor like severe PAH or something, heart disease or some risk for diabetes, something risk factor is there, then the anesthetist used to come and do a PSC, and it is a elective cesarean section. In emergency cases, this PSC pre-anesthetic takeover is usually not done, but it is elective cesarean section and there is some risk factor. Then we are doing PSC checkup. Another thing, another thing you should add that, and it depends upon the anesthetist. If anesthetist is equipped with this epidural, then this is the ideal. But most of the anesthesia, they are preferring cesarean section, which is a short procedure. But if it will be given, then the pre and post-operative care anesthesia also will be taken into care.
So thank you very much. Actually, here is the real gap in the our system, that in cesarean section we are not that particular that we have pre-anesthetic checkup. Though the pregnancy itself poses a very high risk situation, a lot of changes, like what is the obese patient, short neck, then we can have a lot of issue even after the spinal or epidural, that patient has sudden hypoxia and the other issues. So here is the gap, and the peripartum cardiomyopathy. And what is the thing that the Kerala Federation OP, the state chapter of Kerala says that echo for every woman, though it is not practical, not doable for across the country. But now we are having more and more higher age group pregnancy, and these are the again IVF pregnancies, patient on hypertension, that they really need a good pre-anesthetic checkup. So Dr. Piyush Bansal, cesarean OT is just another OT, because orthopedic people and endoscopic people, we are very, very particular in cesarean section, any left out OT. So how we can make very which the cesarean section OT, what are the special about the cesarean section OT, what particular thing it must have, and your comment about the cesarean section operation theatre. Dr. Piyush. Dr. Piyush is with us, or anybody can take it, I think, on panel. In any panel, Dr. Patel, you can take. Dr.
Yeah, madam. When doing a cesarean section OT, most of the time the orthopedic people do not prefer to do in this time OT, because they require more sterilization. When I was in the coal India, that's the orthopedic people, they do not prefer that after doing cesarean section, they will take a operation, mostly. Yes. Second thing, in the cesarean section OT, we should have a baby corner. So immediately can take care of the baby. So that will be not available in other OT. So in the cesarean section, we're routinely doing cesarean section, the baby corner should be attached to that, so that at the earliest the baby can be taken care of.
So thank you very much. So this is a point actually why we have put this before going to the surprises and difficult situation, because we should be in safe battlefield so that we can deal with all the emergencies. So it is not just another room or something. The neonatal station must be perfect with all temperature control, suction, oxygen, resuscitation of baby. Anytime the needed resuscitation for the mother, because it is the most unpredictable surgery where we get on getting the difficult situation, and we always need call for help, whatever complication we have. So we must have all the phone numbers on the intercom or in our list, and all the emergency crash cart, all the drugs, and a very, very high quality cardiac monitor. So this is because if our battlefield is safe, we are able to deal with the situation very, very safely. So these are few papers who says what are the usual difficult situation we will be dealing with one by one. And Maushmi, you go ahead with the case situation and carry on the discussion for this case.
Yes. So a third gravity, rural woman, previous 2 cesarean section with 1 alive child, 1 vertical at the rural health center, and the baby expired after 1 hour. Second transverse incision was Joel Cohen, and the child is 3 years old, alive and well. The mother has come to us with mild pain abdomen off and on, ultrasound report showing 37 weeks gestation, cephalic presentation, placenta upper, and with normal Leica volume. Hemoglobin 10 grams, other investigations with a normal limit. So on examination, fundal height is 36 weeks with a floating head and good fetal heart sound. She wishes to give you a date for cesarean section as she's coming from far away. She's traveling from a far away place. And she's also worried because she has lost 1 child. So is it easy for an obstetrician to now give her a date? Any questions? Like when do we prioritize or how do we optimize her date of cesarean section? Dr. S.J. Patel.
So she's a previous 2 cesarean section and 37 weeks of gestation, and has come from a distant place. So actually, ideally, it should be after 38 weeks. And if you have previously, she has received these antenatal corticosteroids, then you can plan for after 37 weeks because she has come from a distance and the previous 2 cesarean section. But if it is not, she has not received the antenatal corticosteroid prior to that, then preferably you should plan at 38 weeks, complete on 38 weeks, so that you can there should be not any iatrogenic prematurity to the fetus. And second question, madam, timing of cesarean section, ideally I should go at 38 weeks or after that. And for any preoperative preparations, because everywhere we should keep, because prior to cesarean we should be anticipate the complications, so that we should keep or informing the surgeon also, because there may be bowel or bladder deep dense bowel or bladder adhesion. So we should inform the surgeon that we may call you SOS. And also blood should be kept ready because hemoglobin 10 grams since previous 2 cesarean section, anticipating that a blood donor should also be ready for blood if required. And these are the other things.
Yeah, the one good thing is that the placenta is fundal.
Yes,
so it is
no chance of creta in creta, but there may be chances of ectopic creepage, and because there is chances of adhesion.
So your choice for skin incision, one is vertical, one is transverse. So how will you?
Joel Cohen, again Joel Cohen, say transverse, no vertical, never. Never.
So thank you very much. Mostly you go on.
Yes, madam. So, as rightly said, the timing of cesarean section again is a matter of dilemma and has to be weighed case by case. And preoperative preparations for the baby, we can give steroids. For the mother, optimization of blood of hemoglobin, steroid coverage, and during surgery, taking all the precautions, taking a trained assistant with us, and skin incision, as always said, to prevent hernia later. So transverse incision is always preferred.
Before we go to next, Dr. Patel said about the steroid priming. Just we wish to there is even a few months ago that it's okay to give the steroid even in elective cesarean section because it reduces transient tachypnea of newborn. But now with the one important study, it is the last upper limit is a 35 week. If we give steroid and after 35 week don't give steroid because it can have neonatal issues. So any expert comment about it? Because a lot of controversy and the gray areas. Because of course RCOG also said that it reduces transient tachypnea of newborn, but it can have long-term effects. So any comment from the expert about it?
Madam, actually, I honestly tell this, we are giving in every cases, most of the cases, except in very low risk cases, because very often the patient comes with leaking at 35 weeks, 36 weeks, and in that case we refer because you have no neonatal intensive unit or NICU or NSS around the clock. So most of the time, previously we refer the case to a higher center. So if there is any patient history of any pain or any risk factor, slightest risk factor, then we are giving at 34, around 34 weeks, 33 to 34 weeks, we are giving mostly routinely this antenatal.
Thank you very much. Actually, the thing is, I also give most of the time, it is around 36, 37 weeks. But important thing that it has to be documented now, that we are giving a steroid and it can have, it is something. Dr. Gangadhar Sir wants to say.
Yes.
Yes. Dr. Gangadhar Sir is raising her hand.
First, I will ask Renuka to respond first, because Renuka was the co-panelist with. Yes.
Dr. Renuka.
Renuka, you were the, yes, you are coming.
Am I audible, madam?
Yes, madam. Yes, please.
My regards and namaskar to all my seniors, my teachers, and thank you for giving me this opportunity. Madam, if a patient is in labor at 36 weeks, I won't arrest the labor and I'll go for cesarean section in this case.
Very nice. Because she is having 2 cesarean, she has lost one child and she is having mild pain also. So, and she is living long distance. So very rightly say a very, very like a reasonable decision that you wish that it should be delivered. Steroid is a gray area. I think Dr. Gangadhar Sahu will give comment now. It was not that, but now there are inconsistent and conflicting between the professional body because of 1 or 2 papers. So Dr. Gangadhar, your comment about it.
So thank you, Shankar and Renuka, both are my students.
Yeah, namaskar, sir.
I do not want to bring a situation where both of you will fight. So rather I will try to save both of you by giving my opinion.
Thank you, sir. That's the ideal teacher.
So number 1, Sadhana madam, thank you very much. So wish you all the best. First thing is the 3rd gravida, first one cesarean vertical incision, second one cesarean transverse incision, now 37 weeks completed with mild pain abdomen. So my first decision will be, I will do cesarean section as early as possible, with all preparation being taken and keeping in view with all the problems that I will encounter. That is the first. Second one, I want to wait because that's mild pain may aggravate at any time, so that it may give way to the rupture of the uterus. Second thing, should you give the antenatal corticosteroid? So there are different views. So I will follow my view, particularly what I do practice. So after what I teach, after 34 weeks of pregnancy, there is no need of giving this antenatal corticosteroid, even if there are world opinions, even different opinions. So, but 37 weeks, there is no need for giving antenatal corticosteroid. So therefore, straightforward, prepare for cesarean section. Then transverse incision is preferred in this case. If you see something other than any problem there with the transverse incision, I mean vertical incision, that is different issue, but transverse incision is preferred. So 3 things, madam. First one, at the earliest opportunity, I will do the cesarean section, being prepared for everything, because she may have blood loss, anything. Second, I won't give corticosteroid to this patient. And third thing is, I will definitely go for a sterilization operation. In this case, I won't allow for further delivery or cesarean section to trouble neither to Dr. Patel nor to Renuka.
Thank you, sir. Thank you, sir.
Thank you, sir.
For sterilization, 1 child is not alive. So it is all depend upon the patient's consent actually. Today's times are your time was okay, but today we cannot enforce anything. So it is their decision, because one child is lost. So we and pediatrician always are think that let the baby. So thank you very much, Dr. Sahu. So Mashmi, you go ahead with that discussion. Next.
Yes, thank you, sir. So now we have now decided for a cesarean section for her. The skin is opened through a previous transverse incision. While opening parietal peritoneum, there was no space to enter into the abdomen. Uterus was densely adherent to parietal abdomen. So now how do we facilitate? Now how do we enter the abdomen and gain access to the lower uterine segment? The tips and tricks to gain access when in this case. Dr. Jyoti from Muzaffarpur. Dr. Jyoti and Dr. Rashi. Dr. Kanchan.
Hello, good evening, ma'am. I'm Rashi from Muzaffarpur.
Yes, Dr. Rashi.
Good evening, ma'am.
Yes, welcome. Please
Thank you, ma'am, for inviting me to this webinar. For this patient, I would like to slowly go about the dissection process. I would first of all try to open the peritoneum wherever there is I think the translucent space is there, and where I cannot see any bowel or omentum or anything adhered to it. I would like to open that space, and then carefully I would like to go on dissecting the space from the avascular area. I would like to approach the lower segment very carefully, and I would like to feel for the catheter bulb to look out for the bladder, and for the bowel also by seeing through the peritoneum. The translucent space usually does not contain any bladder or omentum, and I would like to use bipolar cautery if possible. If there is any need, I would like to avoid the monopolar this coagulation, because if it bleeds, then it will become difficult to find out any plane.
Yeah, so rightly said. So here in this case, there are risks of, there can be an adherent bladder or an adherent bowel. So when we enter into the peritoneum, we have to be as high as possible to avoid the bladder, and also feeling sure that there is a thin layer to cut, and we are not cutting a bowel, which is very rare. It is a rare possibility that it is adherent to the parietal peritoneum. So sharp dissection, having patience, and layer by layer dissection is very important.
And a good assistant, because that traction and counter traction and cauterizing small bladder is a very, very important. And actually bladder, we in sharp dissection, or when we are just doing adhesolysis, very, very inadvertently, we actually go through the bladder, and suddenly you find that there can be injury. So peanut, and one tip that is making a small peanut, ask your sister to make a small peanut, which actually helps in the dissection, and sometimes the tip of the suction cannula, what we have on the operation theater. So that helps you in going ahead, and a very good counter traction and the traction. So be very, very gentle, be very, very careful. Really, you don't know that when you have done the organ injury. So these are the few things, and always good assistant. Never do cesarean section with any inexperienced assistant. That is very, very important. So now the floating head is the issue. So you have very rightly, Jyoti, you have done all dissection, and now it is a third cesarean, it is elective cesarean, but the head is floating. So your tips and trick, Rashi, for taking out the baby in such situation.
If the head is floating, if I can catch hold of the head, then it's okay. We can apply one blade of the forceps to get the head out, and along with the fundal pressure. by the assistant, by anesthetist, or we can just catch hold of the leg of the baby. We can extract the baby by foot end, by pedalic version in such cases.
So Mashmi, you take over the discussion.
Yeah. So mostly when in case of floating head, so we allow the head to fix when we give a small incision and then allow the liquor to drain out, so that gradually the head becomes fixed and we can deliver the baby easily. We can always use a vectis. We can use forceps or we can use vacuum, but it is always better to actually drain out the liquor and then deliver the head, so that the baby doesn't move away. Again, we struggle delivering the baby.
Any comment about the vacuum versus forceps? Because there are few papers who says that vacuum does cause sometimes the fetal issue, fetal injuries, hematoma. So any comment from the panel that you prefer one blade of forceps, or it is a ventus, which is your common practice? Any comment from the expert?
Not at all.
Both are okay or not? It is.
Dr. Nivedita Bharti, yeah, Dr. Kanchan from Sitamarhi, are you there? What is your practice?
Not at all, ma'am.
What not at all? Just it is safe, or you are using or you are not using. Just we want to say. Actually, what is the point that people are using vacuum? Like many people say that they are using vacuum, but just I want to put that attention that vacuum is made for the vaginal delivery. So it is perpendicular. But in the cesarean section, we need to bring the baby on the skin incision line. So we need the tangential force. So there are few papers who give a question mark that vacuum can be related to some neonatal complication. So it is not about yes or no. I'm just like putting the things that one must be careful, and we are like there has been a vacuum designed especially for the cesarean section. So this is just a point of the thought process to you, what the few good paper says. And the third thing is that the vacuum or the forceps, it should be available. It should be the part of our operation theater trolley. So it is not so that you are struggling with baby and then you say bring forceps to the labor room. Or in some institution, they don't have forceps at all. So that is a matter of great concern. We are having few programs and they say we don't have the forceps in our institution. And that is a real matter of concern. Be it is a cesarean section OT or be it a labor room, forceps is the thing. The assisted vaginal delivery or cesarean section, it should be available. And internal podalic version, what the Rashi also said, in some situation, it is a very rapid, especially in situation, what happens, you are delivering baby floating and then suddenly baby moves away upward. The baby have got its own movement. And in those situations, internal podalic version is very rapid and quite safe option. So Mashmi, you go ahead with that third.
Yeah, so learning points, transverse incision is superior. In where there is a hypertrophied scar or there is a keloid in previous scar, it is a good practice to excise it for cosmetic purpose. And in dense adhesions, sharp layered dissection with particular caution for injury to bladder and bowel. For floating head, we have already discussed. Both forceps and vacuum are used. It is an individual choice. Now, we are going ahead with third cesarean section with phalansteal incision, as in this case. And while we have entered the peritoneum, baby has, while we dissect the bladder, we see that the Foley's bulb is in front of us. So how do we deal with this situation? Dr. Kanchan? Yeah, Dr. Nivedita Bharti, are you there? Or we can have Dr. Piyush Bansal. So there is a bladder injury during cesarean section. So how do we deal with it?
Anybody? I will say, please rename yourself so that we can really. Nivedita said that she left just now. And I think in the chairpersons also, what we have Sandhya Rani is with us, Dr. Indrikala, they can also join as a panel. if we have. So Rashi, you can take. Dr. Patel, Dr. Rashi, you can take it. Dr. Rashi, you
Can I
also
tell,
take
madam?
yourself. Yes, 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 please.
Yes, yes, please.
Ronia is there. She has
I-
joined. Ronia is there. Dr. Kanchan Ronia is there. Rashi, you go ahead, please.
Yes, ma'am. Yes, ma'am. This probably looks like a rupture. This bladder has been perforated because of maybe we stretched the peritoneum at the time of the delivery of the baby. Sometimes because of that also it gets torn up. In this case, I would like to call for the neurosurgeon if a neurosurgeon is available in the vicinity, and I would like to look for the extent of the injury. If it is in the dome of the bladder, then we can repair it easily. And if it is not going to the lower part, like the trigone part of the bladder, then I think it is easy for us to repair with 2,0 Vicryl in 2 layers, and we can put the Foley's catheter after that for 7 to 10 days. And but if it is going to the till the dome of the bladder where we suspect that it could be ureteric injury, then definitely we should not attempt. I think we should call for a neurosurgeon so that they can look for the ureteric opening and all by the cystoscopic, and they can put the DJ stent for that if there is any issue. But most of the time in obstetric and cases we get the dome of the bladder, so that we can also handle it if a person is not available in this case.
Yeah, so repair of bladder injury can be done, is usually done by urologists, but in a setup where the urologist is not available, the obstetricians can also do it, because bladder is a very vascular organ and it heals well. So identifying bladder injury is very easy. We'll see urine coming out of the bladder or Foley's catheter popping out, or there is gross hematuria in the urobag. So this points out that there is a injury, bladder injury. So in that case, if there is a suspicion, we can always do a dye test. So repair of the bladder injury should be done. If it is an extensive injury, then the ureteric orifices should be identified and only then repaired properly in double layers, making sure that there is no urinary leak. And after repair, we can always put a dye, either methylene blue, or we can put a betadine dye, which is colored, fill the bladder retrogradely, and then look for any spillage.
Watch me take the third case, and we will be winding in next 20 minutes. So we will be brief, and Dr. Ojaswini is with us, Dr. Sandhya Rani. So Ojaswini, if you are there, you can, because Dr. Kanchan I am seeing, but somehow she is not able to. So Nivedita, watch me for the case. Yes, next.
Yes. The next case, coming to the next case.
We will be finishing in 15 to 20 minutes.
Yes, madam. Yes. So Gravida 5, fifth Gravida woman, previous 4 vaginal delivery in a PHC, 2 antenatal checkup, has come to our hospital at 11 p.m. right at 40 weeks of pregnancy with mild pallor, blood pressure 140/94 and dehydration. Fetal heart sound is 100 beats per minute. Symphysiofundal height is 40 weeks. Pulse rate is 110 and abdomen tense. Presenting part is not made out. On pervaginal examination, os is 9 centimeter dilated. Head +1. There is caput, thick meconium on pervaginal examination with vulval edema. So now, what will you take straight away to OT, or we have protocol for any preoperative preparation in this second stage arrest? Especially this is a referred case. So what difficulties and what planning are we going to do for this emergency cesarean section? Dr. Renuka Sahu?
Yes, madam. First of all, I'll resuscitate the patient. I'll send the blood for investigation. If she is anemic, then as she is anemic, I'll advise for arrange for blood transfusion, and then arrange OT for cesarean section. I'll give call to anesthetic pediatrician. At once, we have to go side by side for all preparation.
Yeah. So sending all investigations, working her up, Foley's catheterization, antibiotics, broad spectrum antibiotics, and then hydrating the patient. So now, Dr. Sujata, so what are the difficulties we anticipate in this situation? Dr. Sujata, are you there? Dr. Sujata and Dr. Piyush Bansal?
Yes, ma'am.
So after we have now taking it to the operation theater. So what are the difficulties we anticipate in this case?
Madam, first of all, after properly preparation of the patient for the cesarean section, like ma'am said, and all the arrangement made for the baby to be resuscitated after the delivery. First of all, we should give incision should be on the higher side, not very low, slightly above the regular fenestrial incision. And then we will be facing difficulty in delivering the baby because it's been in obstructed phase. So we can do different maneuvers to deliver the baby. If either we can ask our assistant to manipulate to release the head by doing it vaginally, and the same time we can deliver through the cesarean section through our incision, or we can do reverse breech extraction. What we means first delivering out the lower limb, means the legs, and lastly dislodging the head. Or we can do the Patwardhan techniques. This is the one difficulty there will be, and due to obstructed labor, bladder will be little pushed up and edematous. So we have to be little careful about the that portion also, so that while opening the peritoneum, we need to open slightly on the higher side and to be careful while dissection.
Yeah. So we have to individualize this case and give a generous incision on the skin. Generous skin incision, higher peritoneal incision, opening the peritoneum little higher, and then planning the delivery of the baby. So there is a head tightly wedged fetus in birth canal. So how do we deliver the baby? Deeply impacted head. So there are various methods, push and pull technique, and also Patwardhan maneuver, as you have said. Anybody would like to come in with their techniques? Any panelists would like to share the experience?
Ma'am, I would like to share my experience. Previously, I used to do Patwardhan technique, but if your assistant is not very versed with the technique, it's sometimes becomes difficult to dislodge the other arm and then to dislodge the lower portion of the body of the baby. But I find this limbs extraction and lastly dislodging the head portion a bit easier than Patwardhan technique.
Sujata, thank you very much for very earnest thing, because we had the cesarean section, this workshop with the Maharashtra Society, and Dr. P.K. Shah was not at all happy because he was on the call for the a not very well done Patwardhan. So very earnest, Sujata's comment is very, very important, that you must have a practice of it and you must have a good assistant. Push from the below, and you don't have to use one or two finger, it should be from the hand. But the most important thing is that most of the time, as soon as you release the vacuum, the thing is done. It is just the secret is in releasing vacuum, and many times the breech extraction is some of the simplest thing. So Patwardhan, if you are comfortable, it's okay, but there are something real difficult points, because when the hand comes, it is something tricky. Some people find it very easy, but I was really alarmed with the Dr. P.K. Shah's comment that he was not happy because he has found called on the emergency table because of the not very good done Patwardhan. So this open heart discussion is very, very important. So the next question, yes, Dr. Patel.
I just another thing very easy also. The assistant can lift both the shoulder while you are just delivering the impacted head. At times the assistant will lift both the shoulder of the baby. Then at times it will be easier to insinuate below the head and it can deliver the baby also. So your assistant also will do a good job if you can lift both the shoulder.
Thank you. So Mashmi, the next.
Yes. Now the baby has been delivered by various techniques. So suddenly the field is full of blood. When you wish to start suturing uterus, you find difficulty in tracking the uterine edge. So now how do we go ahead? So there is a uterine tear. So how do we now localize the tear and go ahead?
गाड़ी के लिए बोला था थोड़ा इमरजेंसी
Dr. Patel.
Yes, in this case, the externalization of the uterus will help. Yes, and because during the externalization also, both the uterus, kinking of the vessels also at times prevent PPH. So externalization and elevation of the uterus at times helps reducing the blood loss. Similarly, and because when we externalize the uterus, you can see easily the margin of the injury, and you can catch hold with the green armature process and everything. Then if it is due to atonic PPH, uterus is very soft, flabby, then the bimanual compression, and if by doing bimanual compression of the uterus, if the bleeding stops, then this is the way the atonic PPH is there. If there is any, then even after that, you can look for any tissue left, any tissue left inside the uterus, then you should remove the placenta or something inside the tissue. Then these are the processes you can do. Then at the last, if the bleedings are not stopping after that, then you can do this bleeding sutures. This is very effective and so very easy process. Immediately after that, the bleeding stops.
So thank you very much. Actually, whenever there is a difficult delivery, never be in hurry to suture the uterus. See that the posterior part is not sutured to the anterior wall, because everything, if there is bleeding, take your time. Use Alice forceps, use green armitage, delineate that what are the boundaries. And the key point is never be in hurry to suture, because it is a difficult delivery. First you clear your anatomical thing, and then you look for it is a vessel extension or it is a cervical extension. Sometime in those situations, already in obstructed labor, there is a cervical tear. You see, there is a long way, and we have to suture that before we go to this thing. And sometimes the selective devascularization, that is the uterine artery ligation, gives you enough space, though the field is not full of blood. So we will be taking only 1 or 2 cases, and this is very important paper from the France, that the majority of resident OB-GYN are not confident to take the second stage cesarean section, and we need teachers like Dr. Gangadhar Sahu, Dr. Bharati, and Dr. S.N. Tripathi, and Dr. Patel, like thing that we have. So Maushmi, I have to leave at 7:50. So we will, anterior placenta, we will be very brief because I am sharing slide. So Dr. Patel, it is for you. If there is anterior placenta, not percreta, how you go ahead with this thing?
No, I'll try and any sites where the placenta is not there, then I'll give their incision there. But if placenta is totally covering the anterior part where incision have to be, then I will go through the placenta as soon as possible and then deliver the baby. And so this is the process. If there is any space other than this lower margin of the placenta, you can avoid, then you can go through that, assess through that way.
Will not take the placenta perfecta. We will give this time. Yes. Maushmi, you take this.
Yeah.
Yes.
So now while opening, the person observes that the placenta accreta is now bulging through the anterior wall involving the bladder. So now this is a case of placenta accreta on the operation table. So how do we deal with this situation? So now this is an era of placenta accreta syndrome. So who is panelist who would volunteer for this question?
Then these cases we should not dare. If there is no active bleeding, then we should leave the placenta inside and then we'll go for this methotrexate or something, because if we are not confident, our setup is not well equipped with all this situation, then in this case, it is better not to do anything. Rather, give, if there is no active bleeding, we should leave the placenta in the uterus.
If baby is not, now baby is not delivered. Suppose we have not delivered the baby. So in that case,
then we should cut through the placenta and deliver.
So
go through the placenta.
Actually, now this is something important. Everybody. Saiti, please. Saiti, Please see that the only panelists are.
लेकिन हम लोग 6:45 ही देखे ना।
फोन लग रहा है कि नहीं लग रहा है?
फोन व्यस्त बता रहा है।
Please, we are not able to listen. Sahiti, please check.
आधे घंटे पहले भी बिजी बता रहा था, मैं नॉन स्टॉप तो कर सकती हूँ।
Sahiti, please see who is mobile is on.
चार्ज नहीं है, चार्ज है तो बोलो कॉल कर देंगे।
Oh God.
मेरा चार्ज इतना कम है कि कुछ भी नहीं कर पा रही।
इसी टाइप है, हाँ, OnePlus है।
Maushmi, just check whose phone is
मैं आई थी उधर तो मुझे आवाज आ रहा था, तो फिर मैं वापस आ गई क्योंकि वेबिनार चल रहा है करके।
Please mute yourselves. Please mute yourself.
Please mute yourself. Please mute yourself.
आयुष्मान हो रहा है कि नहीं हमारा?
Oh God. Sahiti, are you there? Please see from which phone this voice is coming, because we have to wind up in the 10 minutes. So one thing, if you
अल्ट्रासाउंड रिपोर्ट और ये सब चाहिए तो है नहीं पेशेंट के पास, तो फिर उसके बिना आप कैसे करोगे? अप्रूव कैसे करोगे?
Sahiti, we cannot. Sahiti, please do something. Sahiti, mute everyone. So one thing is there, if there is a single person and you are suspecting placenta percreta, don't start cesarean section. It is better that you transfer the patient and the leaving the placenta if she is bleeding. Actually, she is having the placenta. It is a dangerous thing. And one comment about methotrexate, that many studies are now consistent in that point, that methotrexate does not add to any recovery or any expulsion. Yes, if the placenta is not bleeding, in very, very rare circumstances, you can leave placenta, but it is always better to do the obstetrical hysterectomy. And the second thing, if you are all alone, if you are not having the very good number of blood component, good assistant, good ICU backup, it is always better that you close the abdomen and organize referral to the tertiary care center where everything is available. So this is very, very important message. Actually, I was just thinking. So, and if the patient start bleeding, and never give oxytocin as a active management of third stage of labor if you are suspecting any placenta percreta. So we are not going. It is a common situation that we find the myoma during cesarean section. So Dr. Rashi, your comment about it, when you find, are you doing cesarean myomectomy, or you are doing only when this is obstructing your skin incision line? So Rashi, Sujata, anybody can take this. You are
I do, ma'am. I do it when it is obstructing my incision line, and sometimes when it is, I think it will not bleed much, and I can easily take it out without compromising the patient. Even then, I take out the myoma.
So very rightly said. So cesarean myomectomy is the thing when you are expert in the gynae myomectomy, only then when you think it is the same, it has to be consented. We must have the all backup measure like tranexamic acid, sometime need of the blood transfusion as well. So it must be not a just you see the myoma and you remove it. It has to be consented. The principle are same. You breathe the incision, you delineate the bed and you repair well. But if you think that it can cause PPH, it is not accessible, then it is better not to touch. So I also do a lot of myomectomy, but still we cannot say that we do in all. So we will leave this preeclampsia because we have to see. So now we will be rapid fire. So 32-week leaking with the transverse line. So Nivedita is not with us. So anybody can take. Rashi, Dr. Sujata, Dr. Anybody can take. 32-week transverse live severe oligohydramnios.
Madam, I will refer to a tertiary center because there will be neonatal, neonatal setup will be there, and then I will not dare to do this because in 32 is.
This patient. A trick of delivering the baby in that. Actually, what we want to do. My slides are visible now, Maushmi.
Yes, yes, slides are visible.
So in 2 minutes, we will be winding up because I am sharing a slide and I have something important to leave at 7:50.
So 32 weeks of pregnancy, lower segment is not formed. Plus, there is very less liquor. There is oligohydramnios. The fetus is inside and it is totally gripping the uterus. So this is again a challenging situation. So what are the issues? Anybody can come out. It is on the screen.
That's 2 minutes. 2 minutes.
Difficulty in delivering the baby also there will be there. Then because no like and transverse line.
We welcome Dr. Bharti Mishra. We were looking for you, Dr. Bharti. So we called you so many times. Please give your address. I'm very happy. Dr. Bharti, unmute yourself. Unmute yourself. Unmute yourself.
Good evening, madam. Thank you for the privilege you have
Shall
given
we
me.
wind up the panel?
Yes.
Hello. Because
I think we can
was
wind
busy
up.
in one
Yes.
CS, I could not attend. Emergency CS was there, and CS is our topic. Then I came and saw, and I replied. Okay, sorry, Sadhana. So nice of you.
We invite you. I think we have finished almost all important cases, Maushmi, and we are privileged to have Dr. Bharti Mishra, with whom we will be looking forward. So thank you all the expert panelists for your wonderful comment, very, very honest and earnest discussion about the delivery, about Patwardhan, about OT and the pre-anesthetic checkup. It was great learning and sharing session. And before we say thank you, over to Maushmi for say thank you. Dr. Bharti, please, your pulse of wisdom as our guest of honor and as our expert. Dr. Bharti. Dr. Bharti, please unmute yourself and unmute.
Bharti madam. Good evening, everybody. Greetings from Barampur, Odisha. And sorry that I was busy in one of the emergency CS. So, cesarean section being the topic, the burning topic is discussed because whether you are heading for a more cesarean rate, whether there is no benefit for doing a cesarean section rate is more, and whether it is indicated or not, which place it should be done by whom. So these are the few points I have to tell my things to you. So first thing, all are telling that cesarean section high. But I always tell even the FIGO president that because in India, one thing is required is timely CS. If you do two moribund patients, maybe the outcome is poor. If you don't do, you are resulting in BBF and near miss cases so many. But if you are overdoing also, there may be maternal mortality, neonatal prematurity, and PPH and whatnot. So, in a medical college, I am there. Let me tell my experience. When any patient is coming pouring 1500 to 1200 delivery per month, and there are 2 SR and 2 assistant professor and PGs are managing the cases. We are having a triag room where you take out all the patients, normal delivery we are doing, and that one. Everybody is telling that CS rate is more in private sector. In private sector, we all obstetricians are sending our case, those who should have a cesarean section, elective. And those who want a normal delivery, because no obstetrician is working both the hands, we are sending them to medical college or a center or general hospital in our place to have a normal delivery trial. Even if trial in privately, but you have to give time, no. We cannot depend on anybody for a labor. They must be very well versed to find any fetal distress or any emergency that is arising. And CTG is not available in every place, except in medical college and tertiary center. So, and you know, the small Doppler will act like a small Doppler also. There is a CTG machine. There is a CTG machine also. In this Doppler, you can make it like a Doppler and CTG curves are coming. What you want to know? Acceleration, deceleration, and with the uterine contraction, how it acts during labor. So, cesarean should be done, and mind it, in medical college also, the cesarean should be by the best cesarean section doing by whom we know, not by professor. It is assistant professor with 5 years experience, because they have to tackle. And which are the cases they can seek for GOC or higher when there's a, as Dr. Patel has told just now, that, hello? Dr. Patel has told just now that he will refer. That's a good thing. Prematurity, transverse lie in labor. How can you get it? Because the lower segment is so thick, you cannot get, and there'll be a fracture and everything, and oligohydramnios. So that is the point. Second thing is previous 2 or 1 CS. Patient with spectrum placental adhesion, morbid adhesion. All these things should be categorized to tertiary center. It should be done electively. It will be done by senior obstetrician or in your department, or even unit head, or even assistant professor or professor with a team, and blood should be ready. Everything should be ready. Then it should be done. So high risk cesarean and normal cesarean. In a case of primary fetal distress, you can do, SR can do, and assistant professor can do. With a PG student, they can do. But in a high risk cesarean section, Dr. Sadhana, it has to be channelized to the senior obstetrician, more than 5-year experience as assistant professor. And blood should be ready, the tube should be ready, and the anesthesia is also very important. When you do, sometimes the junior PG itself are coming and they are giving anesthesia. When the patient is going to shock, nobody to revive. In a case of preeclampsia severe, who will give anesthesia? It should be assistant professor and above. That may be SR, that may be PG anesthesia. That is in our medical college, I am telling the practical experience. So one has to do, select the cesarean cases. Don't try to rise the number. If you have induce properly. Induction is halfway. No patogram is maintained. Patograph should be maintained. And it has to be, if you have given cervifine gel once, again 12 hours you can give, if the pelvis is adequate. And adequate pelvis should be done by whom? By whom? Not by juniors. One RS or SR or anything above than that should be doing that. PG should be guided. So the take-home message is that we are not increasing the CS rate. We are also trying our best to decrease by optimum selection of the cases. And prior selection of the cases, give a fair trial. If you are giving a trial, don't interfere in between. And before trial, pelvic assessment, CTG, ultrasonography, nice one is a must, an indication of trial. Then patograph has to be maintained. Then you have chosen which case will be CS and that one. If it's a normal, like primary or that one, you feel that young lady, not anemic anything, you do yourself with a SR and RS on duty. If anything above that, be ready with your manpower, blood in hand, good anesthetist, then it will save the life of the mother and dad. And nonetheless, one pediatrician should be present each and every case of cesarean section, elective or emergency, to take care of the baby. If it is not available in periphery, the gynecology or the obstetrician itself or the sister should be enough qualified or trained so that she can revive the baby if required from meconium aspiration or fetal distress baby born, like that. Thank you very much, Dr. Sadhana, allowing me to give my expert opinion, even though I am not listening of your talk. Thank you.
Thank you, madam. Actually, we were waiting for your blessings and your expert comments. So with this, we wind up our webinar. We have spent from 3 hours time gaining knowledge about a very important and crucial webinar today. So as customary, a vote of thanks, I would like to thank our chief guest, Dr. Professor S.N. Tripathi madam, Dr. Rangila Sinha madam, our guest of honor, Dr. Bharti Mishra, then our chairpersons and panelists and speakers. For the first session, the speakers were Dr. Sandhya Rani Panigrahi and Dr. Indira Palo. My wholehearted thanks for the wonderful presentation. And to the chairpersons, Dr. Dilip Kumar Sarangi, Dr. Stuti Khare and Dr. Sudha Jha. The second session, Dr. Sadhana Gupta madam herself had delivered the talk. I thank the chairpersons, Dr. Ojaswini Patel, Dr. Anju Singh and Dr. Neelam Sinha. The third session was taken up by Dr. Prithviraj Sethi, very excellent talk, and 3 chairpersons who had given their expert comments, Dr. Braja Kishore, Dr. Kamal Prasad Agarwal and Dr. Prachi Singh. And we had a lovely panel with panelists, Dr. Sujata Kumari, Dr. Piyush Bansal, Dr. S.J. Patel, Dr. Renuka Sahu, Dr. Jyoti Das, Dr. Rashi, Dr. Kanchan, and Dr. Nivedita Bharti. And the most important person, Dr. Gangadhar Sahu sir, who has stayed throughout the webinar giving his expert comments. I thank you. I thank all the audience, all the participants who have been throughout in this learning experience. Thank you. And we all just wish and hope and give our wholehearted support to Sadhana Madam, who is the presidential candidature this year. Thank you.
Thank you, madam. Thank you, madam. Thank you.